All right, so welcome back. Tonight we're going to cover two chapters. We're going to first hit lifting and moving patients, which is chapter 3, and then we're going to go a few chapters forward in your textbook, and we're going to talk about patient assessment, and that's going to be a really important, rather large chapter. So, lifting and moving, patient assessment, and then most of what you're going to do this weekend is going to center around lifting and moving patients, loading them into the ambulance, and performing a patient assessment. So this is going to be pretty foundational. So this of course is all derived from the National EMS Education Standard Competencies, and this is a document that you can go and look at yourself. It's on ems.gov, and so this lays out all of the educational objectives that we have to hit as we're going through here. So most of the information that we're going to cover tonight is within the preparatory section, and then within that we're looking at workforce safety and wellness, how to keep yourself, your team, and your patients safe. And then we're also going to cover a little bit of the EMS operations side because it involves, ambulance operations. So to dig into this, as an EMR, you generally are the first on scene, and so you have to analyze the emergency situation and quickly make a determination about the patient's condition so that you can carry out effective life-saving emergency medical procedures, oftentimes while you're waiting for higher skill level resources to arrive on scene. And so these emergency medical procedures may include lifting, moving, or repositioning patients, or assisting other EMS providers in moving these patients and preparing them for transport. So in some cases, your knowledge of emergency movements may be a life-saving skill, and we'll dig into how that can be possible in just a little bit. So some general principles that we want to remember here. Every time you move a patient, you want to keep these in mind. So in all cases, we want to do no further harm to the patient. So in a certain number of cases, we are going to keep the patient right where they are, right where they found them. We're going to treat them in place and wait for higher levels of care. But in certain situations, we're going to move them, right? So we're going to only move them when it's necessary. And before we move them, we're going to consider where they're going because we want to move this patient as few times as possible. Every time we move someone, we have a chance of inducing further injury. When we're moving someone, we move the entire body. So we're not just going to grab one arm and start dragging them across the pavement. We want to move their entire body as a coordinated effort, as a single unit, so that we don't cause additional injury. And then in addition to that, we want to make sure that we're using our own proper lifting and moving techniques and good body mechanics so that we're not putting ourselves at risk. And then generally speaking, we're going to be moving patients as a team. It's going to be you and at least one other person in most cases. And so in that case, one person is in charge, one person is issuing the commands. And this is something that if you work with the same partner routinely, you will establish that rhythm. But it's always good to identify who's going to be giving the commands. Also consider delay moving the patient if possible until you have the right number of people, right? Especially if you're dealing with someone with complex injuries or someone whose weight is a challenge. We don't want to put ourselves in danger, put the patient in danger by trying to move this patient without the appropriate number of resources. We also want to treat the patient before moving them unless the patient is in an unsafe environment. So in most cases, our priority in most cases is to treat life-threatening conditions. And we're going to get into more of that when we talk about patient assessment and the primary survey. But in all cases, we want to identify what are the things that are going to kill this patient immediately. And some of these things would be the patient's on fire, or the patient is drowning, or the patient is in a building that is imminently collapsing. And in those cases, your life-saving treatment is going to be removing them from the environment that is killing them, right? And so that is where patient movement techniques are going to be life-saving in nature. However, If they aren't in that situation, if the environment isn't what is killing them, and say they're bleeding to death or their airway is collapsed or something like that, then you're going to want to treat the bleeding. You're going to want to open the airway and make sure that they're breathing first, and then worry about moving them later. So movement in and of itself may not be the life-saving intervention, and if it's not, then you have to treat what is going to save their life. One of the things you'll probably hear us yell at you a lot for is do not step over your patient, ever. When you step over the patient, not only do you risk kicking them, but you also risk dropping dirt on them and into their wounds from the bottom of your boots, dragging equipment across them, tripping and falling over them. So it's a hazard sometimes to you, but mostly to your patient. So don't ever, ever, ever step over the patient. Always move around the patient. And then finally, especially when we're lifting and moving them, it's really important for us to explain to the patient what we're doing, to give a measure of psychological support and so that they can help us move them. And generally speaking, there's no reason to hurry the moving process. If you think that the patient has sustained trauma to the head and spine, obviously we want to prevent further injury. And so we're going to keep the patient's head and spine immobilized, or at least limit the movement of their head and spine so that we don't induce additional movement into their potentially broken bones. And in all cases, we want to know our own physical limitations and our own capabilities. One of the things that is important for this line of work is that we remain physically fit as a protective mechanism for our own bones and joints. There's nothing that's going to induce an injury faster than not being physically fit enough to do the work that you do. And so you need to know your own physical limitations and capabilities and also work to improve them. Make sure you keep yourself balanced when lifting and moving. Make sure that you maintain a firm footing. Generally speaking, you want your feet about shoulder width apart, and you don't want to move your body away from your center of gravity. And we'll get a better sense for that tomorrow when we start doing these skills. Lift and lower the patient by bending your legs. So what you're going to be doing a lot of sort of squatting type motions. You're going to be lifting with your legs and not lifting with your back. Now, in some cases, it may not be possible to use perfect form, but you want to position yourself so that you can use the best form possible, right? And so reaching all the way over a hospital bed to slide a patient over on a blanket, is it good form? Absolutely not. Is it necessary sometimes? It can be. And you want to make sure that you are putting yourself in a position where you're going to limit the amount of stress that you put on your own body. And then finally, one of the ways that you're going to limit the amount of injury that you do to yourself is to move the patient as few times as possible. If we can get them over onto the bed in a smooth and gentle manner in one movement, then that's what we're going to do. The other side of that is if we have to take 3 attempts to move someone over, or we have to move them in 3 small movements in order to keep ourselves safe, then we're going to do that, right? That will be the minimum number of moves possible. So don't be the joke about trying to get all your groceries on your arms to make one trip in from the car after grocery shopping. Sometimes it doesn't work. Sometimes those bags break. Sometimes you slip, trip, and fall, and now there's a yard sale of groceries across your front porch. And while it's hilarious for other people to see that happen, it's not so hilarious when the patient is what's yard saled across the emergency scene or across the hospital floor. And I have a great video if we have time later on. I have helmet cam footage of when I was in Afghanistan, and we had a local team carrying a patient out on a stretcher, and this team was 1 Navy corpsman, which is the medic in the Navy, and it was 3 Afghan National Army medics, in big air quotes there, and they were running towards the helicopter, which is your first mistake. There's no need to run most of the time. And the second mistake was that they didn't secure the patient to the litter properly. And then the third mistake was because they were running and because they didn't secure the patient properly, one person tripped because they weren't strong enough to hold the litter, and you just see the litter tip over, the patient splash into the crushed rock on the landing pad of the helicopter. All of the blanket went flying and got whipped up into the air under the rotor wash. It was a bad situation. And so they took an already bad situation and they made it worse. So I like to say that running will save you seconds, but tripping will cost you minutes. And so it's always better to take your time and do things in a smart way. So the first thing we're going to talk about is the recovery position. And this can be a complicated concept for a lot of people. So I'm going to talk about it for a little bit longer than I normally would. So the recovery position is going to be something that you use when the patient has no life-threatening injuries and does not need any further medical care, and you are not going to be present to make sure that their airway stays open. And so when are we going to use a recovery position? This is going to be used in a mass casualty situation, or when you have more patients than you have resources. And so if you're the only person on scene and you have 2 patients, maybe one of them is going to wind up in the recovery position, right? And so what is the recovery position? This is for unconscious patients who have not suffered any trauma and don't need any further care or reevaluation, or you don't have the ability to give them further care or evaluation. And so this is a position that allows them to keep their airway open and allows secretions to drain from their nose and their mouth. And so what are we going to do in this position? Well, we're going to roll them over onto their side. We're bringing up one knee, and that knee helps prevent them from rolling completely over on their stomach where they may asphyxiate. If you roll over onto your stomach and your face is in the ground, then you may not be able to breathe effectively, especially if you vomit or if you have secretions coming from your nose and your mouth. The next thing we're going to do is you see that the hand is up on the arm. Sometimes that arm is extended up over the head with the hand sort of under the face. And what this does is it cradles the head, maintains it in a neutral inline position, and then also allows for any vomit or blood or drool to drain from the face onto the ground so that they don't, again, drown in a pool of their own secretions from their nose and their mouth. And again, this is not something that we're going to do for a patient who is on a cot in an ambulance. This is not something we're going to do for a patient that we are actively assessing and reassessing. This is something that we do only for a patient who does not require further care immediately and for whom we don't have the ability to stay by their side and actively attend to them, right? So this will come up later. I always get questions about whether and when this is appropriate, so don't be afraid to ask questions because this is a confusing concept. But again, this is going to be something that you use in the instance of like a mass casualty situation or something like that. So let's talk a little bit about body mechanics. Your top priority as an EMS professional is to ensure your own safety. Your safety comes before the safety of all others. It's your safety, it's the safety of your team, it's the safety of the patient, and it's the safety of the general public, always in that order. Because here's the fundamental truth. If you are the highest medically trained person on the scene, which oftentimes you're the first person there, and so you are going to be the most medically trained person there, if you get injured, if you become a patient, well, now there's nobody medically trained on the scene. You need to keep yourself safe so that you can save other people. And part of, the most frequent danger you're going to run into is your own bad technique. And so by using these improper lifting and moving techniques, you can injure yourself, pull your back, sprain something, and now you're out of commission, you're out of service, and you're no longer any good to the public. So good body mechanics reduces this possibility of injury. And generally speaking, we want to use the strength in the large muscles of our body, our legs, to lift the patient instead of using these smaller stabilization muscles like the muscles of our back and the muscles of our core. And so here we see a gentleman that looks like he eats at gas stations often. However, he is maintaining a good body position there. He's keeping the weight of the patient close to his body. His arms are extended. He's not trying to lift this person up to his chest, right? We can see that his feet are spread, that his center of gravity is over his feet, right? So this is a good lifting position. So again, we want to keep our back straight. We want to activate our core. And what does that mean when we activate our core? Well, the best thing that I've heard is that if you imagine a string from your belly button to your back, you want to pull on that string, sort of bring your belly button in towards the back of your body, and that activates your abdominal muscles. Not because you're going to lift with your abdominal muscles, but what it does is it tightens up your core and makes your upper body more stiff. And then what we're going to do is lift with the legs of the body. So we're going to get into that squatting position with our back straight over our squatted legs, and then we're going to lift straight up. And so we don't want to have any sort of quick jerking motions. We don't want to twist our body. Make sure that we have firm footing before we start to lift. Get a good sense of the weight of the patient and know that the top half of the patient's usually the heavier part, and know your own capabilities. If you need it, call for additional personnel. Now, this isn't always not always going to be a quick call for help, especially if you're working in the North Country or the western part of the country, where we're already experiencing a big provider shortage. One of the reasons why this course is going on. But if you think you're going to need help, call for additional personnel early. Make sure you're communicating with the members of your lifting team. Make sure that everyone is where they need to be, is ready to lift. And part of this is going to be practicing with your team and making sure that everyone is on the same sheet of music. And we'll give you some tips for that tomorrow. So the emergency movement of patients. So we talked about how lifting and moving can sometimes be a life-saving intervention. And this is what we're talking about here. So you want to move a patient immediately when there is a life-threatening situation that's going to cause them immediate danger or harm. So this is danger of fire, explosions, structural collapse, if there's any hazardous materials present. If the emergency scene can't be secured, for example, if they're laying in the middle of the highway, even if it's a warm, bright, sunny day and there's no, it's not raining out, there's no chance of hypothermia or anything like that. Nothing's on fire, nothing's exploding, nothing's leaking weird hazardous green stuff. The fact that they're in the middle of the highway presents a dangerous scene, and not just dangerous for the patient, but dangerous for you as well. So you want to emergently move them to a safer location so that you can start the patient care process in safety. If it's otherwise impossible to gain access to other patients who need life-saving care. So an example of this is if you have a patient who is blocking your entrance to a vehicle and there's no other access to that vehicle, and you see that other patients potentially need, for example, bleeding control, or they need their airway emergently managed, you're going to need to remove the first person in the way before you can get to the second person who needs life-saving care. And then finally, and this is probably the most common reason for emergent movement, or at least the sort of emergent movement that I've done most in my career, is a patient is experiencing a cardiac arrest and they need CPR, but they're wedged between the bathtub and the toilet. There's no way you're going to get 5 firefighters in a tiny bathroom and do effective CPR when the patient is on the floor, between the sink and the trash can. Just not going to happen. So this patient needs to be very, very quickly moved into a space where effective care can be performed, right? And we're gonna do high performance CPR in week 2, and so we're gonna get a sense of what it's like to be part of a team doing CPR. Everyone here is CPR certified, and so we get the basics, but we're really gonna put it all together, and you'll see why this is important and how much room it takes to actually run an effective code. So the first thing we're going to talk about here in terms of the logistics of moving someone is emergency drags. So if the patient's on the floor or on the ground during an emergency situation, and again, this is an emergency drag. This is not something that you're going to do for every patient you encounter. You may have to drag this person away from the scene instead of trying to lift and carry the patient, right? So again, some tips and tricks here. This is the simplest way to move someone, is to just grab them by their clothing and drag them from point A to point B. But it's also one of the more difficult ways to do it because there's a lot of friction between the person's body and the ground surface. And so this is going to be one of those instances where you need to know your limitations. I can tell you that practicing this a lot in the military, it takes a lot of muscular strength and endurance to pick someone up and bodily move them from point A to point B. So the easiest way to do this, or I shouldn't say the easiest, but the most common way that I've seen this done is the clothes drag, where you're going to just grab a piece of clothing, usually either the tops of the shoulders or the fabric underneath the armpits on each side of their body, and then try to get them up as much as you can using a good lifting technique, and then walk backwards in order to drag them along the ground, right? In all cases, you're moving them along the long axis of their body. That is, their feet follow their legs, follows their torso, follows their head, right? And this is the direction that we want to drag them because it keeps the spine in a straight line. And we always want to keep the spine in a straight line. And again, this is for dragging them out of danger. So in most situations, you can easily determine whether the emergency movement is necessary. And again, we talked about this: on fire, drowning, cardiac arrest. But you have to judge whether the basic life support or advanced life support can be performed in the small space. And so here in the picture, we see this lady being dragged out of a bathroom stall. Again, it's going to be really difficult to get in there and perform effective CPR, airway management, delivery of an AED shock. Once the paramedics show up, they're going to show up with their big monitors and their drug bags, So we're thinking ahead here, and it would be much easier if we dragged her out onto the tiled surface where there's not a whole lot of obstructions, right? And so that's going to be a call that you make very quickly upon arriving on scene. Now, the next thing we'll talk about is the blanket drag. Now, I've done this a lot less often because it just doesn't make sense in a lot of situations. But getting someone on a blanket is something that you will do all the time. The standard blanket on an EMS stretcher is like the best lifting and moving system that anyone has ever created. And in fact, when you look at some of these higher end lifting and moving systems, a lot of times they're just a really big, really sturdy blanket with handles on it. And so we're going to get some experience with putting people on blankets and using blankets to move them tomorrow. But specifically, this blanket drag is, again, if the patient doesn't have clothing to grab, or they're just, for some reason, just difficult to move, what you're going to do is get them on the blanket, which we'll discuss tomorrow, and then use the blanket to drag them across the surface. Now, if you have more than one person, and if you're able to get the stretcher in there, then it would be much more efficient to simply lift them up using the blanket and place them on the stretcher because it has wheels and can be moved easily. And we'll do that tomorrow. So the arm-to-arm drag. This is sort of a step up from the clothing drag, and what you're basically going to do is you're going to reach in through their armpits, but instead of grabbing their clothing, which is likely to ride up and sort of get up underneath their neck and maybe cause some discomfort or pain for the patient, you're going to get in there and either grab your own arms or grab the patient's arms, like you see in the picture here, and then use that. Using good body mechanics, you're going to keep your back straight, your core engaged, you're going to lift up with your legs until you're in a standing position, and then a good portion of the patient's body will then be off the ground, and again, you can walk backwards and drag them out of the emergency situation, right? But again, this is not something that we're going to be using routinely. If there's no emergency, no reason to drag them emergently. So this one's always a hoot. It's in the book. It's on the slides. I've only done this once, and it was in the military, and it was something that we did under simulated gunfire. So this is not something we're going to be replicating tomorrow. I promise I will not expose you to gunfire at any point during this course intentionally. But this is the firefighter drag. And so somehow you're going to tie the patient's hands together. So you're going to take the time in an emergency situation to bind the patient's wrists together, to drape them over your neck, and then crawl on your hands and knees out of the emergency situation. And so I imagine a lot of folks here have taken Fire 1, and we know that we stay on our hands and knees when we're doing a primary search of a building that's actively involved in fire. So imagine doing this with your bunker gear on in a smoke-filled room. Imagine taking the time to tie someone's hands together in a smoke-filled room in a building on fire. And you can already see that there's maybe some logistical concerns with this. Not to say that it isn't effective. I've done it. It works. It takes a lot of time. It is physically very taxing, but it does work. I struggle to find occasion to use it. Emergency drags from vehicles. So this is when the patient is sitting up and you need to reach in and emergently get someone out of the vehicle. Now, what are the problems with this? Well, the problem is that when you have access to a vehicle, it's usually through a side door. So we've been told that you always want to move the patient in the direction of the spine. You want to keep their spine straight. And that's not possible if they're sitting in a car and we're reaching in from the side. So how are we going to get them out while following all of these rules about patient movement? And the answer is we're going to do the best we can, right? Because again, this is an emergency drag. We're trying to get them out of the vehicle because there is some threat to their life, limb, or eyesight, and we need to get them out immediately. So we're going to apply as many of the basic movement principles as we can, but we're going to slightly modify them because, again, we can't get in behind the patient's not lying down. So for one rescuer, we're going to reach behind their back, we're going to grasp under their arms, we're going to try to cradle the patient's head between our arms as much as possible, and then we're going to rotate them down into a semi-laying down position with their head against our chest, and then using that same drag where we're either grabbing our own arms or we're grabbing the patient's arms, we're going to walk backwards and drag them out of the car. Now here's a pro tip for you, all right? This is something that you learn through experience, so learn from my mistakes so you don't repeat it. Unbuckle their seatbelt before you do this. Just a pro tip there, all right? All right, moving on. If we have 2 or more rescuers, then one can support the patient's head and neck while the second rescuer moves down the patient, lifting under their arms. A little bit more cumbersome to do. If you have a backboard, then there are techniques that we can get a backboard in there. We can rotate them, lay them down, and pull them out. But it takes a little bit more time, a little bit more resources. If you're a first responder on scene in a personal vehicle, you may not have a backboard, right? So you do the best with the resources that you have. All right, so before we get into these non-emergent carries, including this circus show here, does anyone have any questions about emergent patient movement?
So, as an EMR
Chris, were you
level,
were you in the infantry?
no, I was a scout, but
I see you wrote infantry favorite position.
yeah, I know.
I assume that was the with the hands tied.
So
Can't
as an
hear you.
EMR,
I see your name popping
are
up
we
like you're talking,
allowed
but I can't hear you.
to?
All right. Well, we'll move on. Okay. So You will sometimes come across patients who cannot walk themselves to the ambulance for a variety of reasons, whether that's medical or because they're traumatized or
Christopher, I can
maybe
hear
they're
you.
just unable to move for some reason. In those cases, you're going to use these non-emergent, non-ambulatory carries. Now, again, all of this is assuming that you don't have access to a stretcher or a cot and that the patient needs to be moved. Now, it ends up in the modern age that that doesn't happen very often. Usually, you need to move the patient onto the cot or the stretcher or the litter, whatever nomenclature you want to use. And a lot of times, you can just keep the patient where they are until it's time to move them onto the stretcher. Um, oh, someone's telling me I have a problem with my sound. Probably because my volume was turned down. That makes sense.
Hey, Max, can you hear me?
I can hear you now.
All right, cool.
Yep.
Can you hear me now?
I can. I can. It was an issue between the user and the interface.
Oh, that's all cool. Yeah, my question though, my bad, was at the EMR level, are we allowed to put a neck collar on a patient?
Absolutely, and we're going to learn that
Okay.
skill during the splinting section.
All right. I just wanted to I only wanted to ask that because like in the picture of that like dude pulling out that woman from the car, like I would assume that you would want to slap a neck collar on there first before you do
So
anything. It just the picture just looked interesting.
yeah, well, and we're
Yeah.
going to talk a lot about cervical spinal precautions
Yep.
and cervical or spinal motion restriction. We don't just strap people to backboards and we don't just slap C collars on people anymore because thanks to science, we now know that in some cases we were causing more harm to the patients and we weren't doing anything. And a lot of the evidence points towards C collars also not doing much in terms of medical intervention. And so we will absolutely teach you how to appropriately size and place a C collar, but we're also going to go over when you would apply a C collar and things like that.
So so you're saying is they got rid of the C collar in certain aspects now? I mean, even
No,
in like a
they did
scenario
not
like
get rid of
that?
the C collar. It is still something that we carry on
Yeah.
every ambulance and something that I'm going to teach you how to apply. But there are times when you apply a C collar and times that you do not.
Okay.
And so we're going to cover all of that during the during bones and joints and muscles and that sort of thing. Were there any other questions while I had my sound down?
As far as the backboard, I thought we were, I mean, I know we have them on our apparatuses, but I didn't think we were using them anymore.
So a backboard is a lifting and moving tool. The backboard is not something that we use for immobilization of the spine because, I mean, scientifically, we've determined that you can't immobilize the spine. It's not something that we are capable of doing. And then, second, whenever you put someone on a backboard, you have roughly 20 minutes before you start causing skin damage. And it becomes extraordinarily painful after about 30 minutes. And so when we consider that the first tenet of our job is to do no harm, then we can immediately see that backboards are doing harm. And so they are lifting and moving devices only. Does that make sense?
Sure does, thank you.
Awesome. All right. So let's move on with this. So I'm going to go through this stuff pretty quickly. It's interesting. It is not something that you're going to use every day, but these are options for you. All right. So the two-person seat carry here, you can see that this is appropriate for patients who are very small and easy to carry. You basically form a chair and drape the patient over the chair, and then they hold themselves up by putting their arms around the rescuers. You can imagine that this is not something that's going to be feasible with larger patients. It's not something that's going to be feasible for patients who are unconscious. So again, it's an option and not widely applicable. Next up, we have the cradle and arms carry. Again, this is appropriate for children. What you're going to, sort of the key points here is you're going to use the crook of one elbow to support the head and neck, especially in small children when they have underdeveloped musculature and a proportionally larger head. You want to make sure that you're supporting that head and neck so it doesn't just flop around. But again, recognize your own limitations. Kids put on weight pretty quickly, and so the difference between a 30-pound baby and a 70-pound child is pretty significant. And so don't just try to scoop someone up with poor lifting and moving technique, because I can tell you a great many parents have suddenly discovered that their children have put on weight when they go to scoop them up with bad form. Two-person chair carry. So this is a throwback from the time before we had stair chairs. This is a great movement technique in a mass casualty situation if you have access to chairs on scene. A couple things I will caution you about. Make sure the chairs are sturdy enough to transport your patients. The last thing you want to do is pick up this chair and then realize that it was the $2.99 special that the company cheaped out on, and that leg just bends and breaks off in your hand and you've dropped the patient onto the floor. But this can be a great lifting and moving technique in a mass casualty or resource limited environment. And this also is very similar to the stair chair, which is a common piece of EMS equipment. The pack strap carry here. This is going to again be sort of it's for non-ambulatory patients. It's a little bit more of an emergent move. It definitely not taking into consideration, traumatic injuries and things like that. This is assuming that this patient is just unconscious and not significantly injured, and you're moving them from, say, where they were injured to a casualty collection point during a mass casualty incident, right? So this is, again, not standard of practice, but it is an option just in case. Direct ground lift. This is going to be something that we do tomorrow when we're picking people up and putting them on the stretcher. This is used for moving a patient who's on the floor, and should you really be used for patients who haven't sustained a traumatic injury. But again, this is how you move someone from the floor to the stretcher. You're going to do the best you have with the resources you have available. So the positioning of your body during this lift is really important, and poor body mechanics, like using your back to lift them, is really going to have a high likelihood of inducing injury. So when you once you get them onto the stretcher, you have to move them to the bed, and then likewise, if you're ever called to do an interfacility transport, you need to move them from the bed to the stretcher. The same with calls to nursing homes and things like that. And so in both cases, you want to place the stretcher as close to the bed as possible. Make sure the railings are down on both beds. Oftentimes you'll have sheets or blankets underneath the patient, and these are great for reducing friction and allowing you to slide the patient over. So we're going to loosen the sheets up from both sides. We're going to have one person pulling on the sheet from the stretcher. We're going to have the other person lifting and sort of pushing the patient from the other side, and they should slide gently right over onto the stretcher. And so really the key here is you don't want to do this all at once if the patient is of substantial mass, and you don't want to do it in swift jerking motions. You want to do it in a smooth motion with good coordination between everyone involved. And again, if you do this poorly, there's a high likelihood of injuring yourself. And so what we see here in the top left side, we see that they are positioning the patient onto a blanket. And so in this case, we see that they've rolled the patient up, which indicates that they're performing what we call a log roll, where we're going to put a blanket underneath the patient. We'll practice that tomorrow. And then once the patient's on the blanket, We see that we move the stretcher as close as we can. The railings are down. We're reaching across. The people on the stretcher are going to grab the side of the sheet closest to them, while the people on the other side of the stretcher are going to lift and push. And we can see that in order to maintain good body mechanics, they've actually moved up onto the bed, right? Because the worst thing you can do is try to be lifting with your back, leaning all the way across a hospital bed. That's a sure recipe for disaster. All right, so sometimes you'll come across a patient who can walk with assistance. And again, we want to limit the amount of movement. So just because someone can walk doesn't mean we should necessarily just be walking around on scene before the ambulance arrives. So we're going to get them up and we're going to walk them over to the stretcher. Now, best case scenario, the stretcher is going to be right behind this person, and we're going to simply lift them up, turn them around, and have them sit down on the stretcher. But if they need to walk down a couple steps off the porch or something like that, then this is what we'd use this movement for. And again, the less capable the patient is, the more personnel that we will need to move them. But then understand at a certain point, you don't want to be standing this person up and walking them to the ambulance, right? So if this person's having breathing difficulty, if they're having chest pain, if their leg is broken, then we're not going to pick this person up and walk them. We're going to lift them and place them on the stretcher for a variety of reasons. All right, and so if you're not familiar, this is what a modern stretcher looks like. This one happens to be a sort of a top of the line model. This one has controls that will automatically raise and lower it. It uses a battery system and hand controls at the foot, but it can also be manually operated. This is in the full up position, and in this position, the patient is sitting at about chest level for your average height person, right? Which is really, really high up off the ground. And generally speaking, wheeling someone to and fro with them that high up off the ground is again a recipe for disaster because their center of gravity is so high and the wheelbase is so narrow. If this were a pickup truck, you wouldn't want to take any sharp turns in it because the thing's going to flop right over. And if you go on YouTube, I'm sure you can find plenty of videos of patients falling off stretchers because people just weren't paying attention and using good technique. So generally speaking, when you're moving these stretchers, you want to have at least 3 hands on them at all times, right? So I haven't met too many people with 3 hands of their own. So what I'm saying is you need at least 2 rescuers and 3 hands on the stretcher at all times. And then when you're moving it around, you want it in sort of a mid-level position where you can push it comfortably, but the patient isn't all the way up in the air. If the surface is smooth, then this thing rolls like a dream. If you're trying to roll it down someone's dirt driveway with clumps of grass sticking up out of it, you're going to need more people to move this. I can remember one of the worst case scenarios that I've ever encountered is we had a layer of snow, and over the top of that layer of snow we had a crust of frozen snow, and so you'd step on it and then you'd break through, and this was about maybe 6 inches thick. And then we went in, and the lady was probably 350, 400 pounds. She was in extremis. She was, basically just a collapsing airway that needed emergent care. We needed to get her out of the house as quickly as possible and into the ambulance where we had all of our equipment, all of the additional equipment that we needed to really work on her. And it took probably 7 people on that stretcher to move it. And pretty much what we did is we just picked it up and carried it over the driveway because we could not roll it through that snow. And it took us far longer to get down to the ambulance than I would have liked. And so that's an extreme worst case scenario. But fortunately, we had the manpower on scene, and the stretcher that we were using, which is this one right here, gives you ample room along the side to get extra rescuers in there and help carry it. And so you may not have a Stryker stretcher. You may have something different, something older that's manually operated. but by and large, most of these stretchers are designed to have extra people in there to help carry them. So speaking of some older stretchers, this is either a stretcher or a litter. Sometimes it's called. You'll find these oftentimes in sort of disaster caches and things like that. These are often used in decontamination sites because they're very quick to clean and are relatively cheap to buy in stock and stick in a warehouse somewhere. So you don't have the benefit of wheels on this, but you have the benefit of it being nice and light and easy to carry around. Here's a picture of a really, really old stair chair. They look a lot more high-tech nowadays, and hopefully a lot of your departments will have a newer stair chair. But basically the premise of this is just like that chair carry that you saw before. We're going to put a patient who can sit, but who cannot walk downstairs. That's right, it is very well used. It looks like it has the coating of 100 house fires on it. You're going to sit the patient in there, you're going to strap them in, and then you'll be able to either carry them downstairs or carry them through a narrow hallway or something like that. And modern stair chairs will also have a set of treads on them that make it just really exceptionally easy to roll someone down a flight of stairs. And so if we have those available, I certainly want you guys to see these, but I know that we don't have them at all three of the facilities, so it's not built into our training curriculum. But if you go back to your department, this is certainly something that you need to pull out and familiarize yourself with. It's specifically the model that your department uses, because there's a couple different types out on the market. So immobilization devices. The next few slides are outdated and are not in keeping with the protocols of the state of New Hampshire, and they're not in keeping with the best available science. But I will move you through these slides relatively quickly just to sort of familiarize you with the equipment, because you still do have long backboards on the ambulance, but they are not used to immobilize patients. All right. So patients who have suspected neck and back injuries, we need to limit the amount of movement that these patients are exposed to, right? And we found that the number one best thing for immobilizing the spine is the patient's own body, right? So you have muscles and joints and bones, and all of these work in unison to immobilize your own spine. And so I will give you an example, and anyone can chime in, but here's a question for the group here. Anyone who has ever broken a bone, what is the first thing you did to that broken extremity, right? What is the first reaction that you had when you broke that bone? Anyone who's broken a bone can chime in.
My mom had me level my arm. Keep it level.
So before anyone told you what to do, what did you do on your own?
I kind of grabbed it and just kept it close to me and still.
So what you're saying is you had a natural inclination to immobilize your broken bone. Would you say that's true?
Yeah.
Yeah.
I'd agree with that myself. I've broken a few bones myself, and it seems to be the common.
Yeah, the first thing you do is you don't want
grab it.
You don't want to move it. Like even if I've seen some people like break their arm and they just like let their arm hang and they're absolutely still. It's like they're like a street performer frozen in time, and they're just like, I'm not moving it. Don't touch me. Don't do anything that's going to move it, right? And so the body's natural reaction is, and much of the pain from a broken limb comes from your body immediately tensing all of the muscles around it, right? Your body's natural reaction to anything that's broken is, for God's sake, don't move it. And the same thing applies to your neck, to the muscles and joints of your spine. What we found is that people with broken backs and broken necks are not moving their backs and necks voluntarily, right? they're going to immobilize themselves. And we found through studying this that them immobilizing themselves is far more effective than me grabbing their body and trying to immobilize it, because effectively what I'm going to do is I'm going to immobilize their body according to my own frame of reference. So they're going to stay still, but I'm not going to stay still, and all of my movement is going to be induced into their neck and back, which is terrible, objectively terrible. So the number one thing that we can do is allow them to immobilize themselves. Number two thing that we can do is limit the amount of motion that we put into these potentially broken bones. And so we have a device in every ambulance that is slightly scooped. It's nice and squishy, and it tends to immobilize our patients extraordinarily well, and that is the stretcher. And so what you'll see in the New Hampshire protocols and many protocols across the nation, and you'll see that the EMTs, advanced EMTs, paramedics, nurses, and physicians who are trained to do this, is they will use the backboard to move the patient to the stretcher, and then they'll immediately take the patient off the backboard and leave them on the stretcher, because it's a much more effective immobilization device. And so anyone who has worked in ski patrol or anyone who has taken EMS classes, 10 years ago or more, may be inclined to immobilize someone to a backboard, because that was a really big sort of symbol of our profession. But we've learned through scientific research that it just, number one, it didn't do the thing we thought it did, which is immobilize, because if you don't do the skill right, the patients are sliding around on this hard, slick surface. And then second, it's actually causing more harm than it potentially saves. So what we found is like single digits percentage of people that we immobilize actually had anything wrong with their spine, but a large number of patients that we put on spine boards developed ulcerations of the skin, complained of pain, and had long-term pain effects from that. And so let's stop hurting people. And yeah, so Anna just dropped in the chat, and I had one of the instructors last class had the same experience. They were in a car accident, strapped to a backboard, and just due to the nature of our trauma systems, stayed on that backboard for several hours. So Anna, if you're willing to pipe up, can you tell us the situation there?
Yeah, sure. Can you guys hear me?
Yes.
Okay. Yeah, so I also got into a car accident and broke my back and was paralyzed from the waist down. And they put me on a backboard and transported me to the hospital on that. And then I stayed on that at Littleton Regional Hospital until they sent me to Dartmouth. And I went to Dartmouth all the way by ambulance on the backboard as well. And it was awful. It was the most painful. I mean, I just remember being like, get me off this thing.
Mm-hmm. Yeah, and that is an experience that many people have endured at the hands of EMS for decades and decades, upwards of 50 years that we've been doing this before we stopped. And it causes real harm, and it has no discernible benefit whatsoever. It does not do what we think it does. It only causes harm. And so I'm sorry you went through that, but now we're learning better, we know better, and we're going to do better. So this is a long backboard. It is a lifting and moving device. It's used for getting people out of vehicles and moving them across terrain that would be very difficult to get a stretcher across. And so they're still on ambulances, and they should absolutely be used when appropriate, but they are not used for immobilizing any part of the body. They are simply used to move people around. Now, something else you may run into that's no longer used is these short backboard devices. Some of the brand names are the KED, or Kendrick Extrication Device. There's also the Oregon Spine Splint, and they are very similar, and they are completely unused because, again, this is not something that has a proven benefit in the context that we started using it. So for the Kendrick extrication device, this was a special device that was used for removing drivers from crashed stock cars, right? So unless you're working in-field medical support at a high-speed racing event, or you're pulling people out of the hatches of armored vehicles, this is not something that you're going to use on your ambulance in regular civilian practice. This, however, the scoop stretcher is something that is wonderful, absolutely fantastic lifting and moving device. And basically, what this is, if you can imagine, if we took a backboard, we cut it in half, and then we linked it together at the top and bottom so that you could slide it in from both sides and it latches together. That's what you get here. And so this is just a fantastic piece of equipment, especially if your patient is injured and you don't want to log roll them. Specifically, we use this for suspected hip fractures, because a hip fracture, we don't want to roll them around. And we'll talk more about this when we get to bones and muscle injuries. But this is a fantastic piece of equipment. There's lots of different styles, so this is a slightly older version. There are newer plastic versions that work just as well, and it requires a little bit of it requires generally 2 rescuers if you want to do it well. It requires a little bit of coordination. You need to play around with the equipment so you get a sense for how those things latch together at the top and bottom. So again, this is not something we're going to have a lot of practice with during this course, but it is absolutely something that you need to go out to your department and see what is on your ambulance and get familiar with the equipment that you are going to use, because they're all a little bit different here. But this is a fantastic piece of equipment. All right, and so we talked a little bit about improvisation last class. Dave was like, you're not always going to have all the resources you want, especially if you arrive before the ambulance does. And so especially in the case of emergent life-threatening situations where you have to move the patient out of an area very quickly, for example, fire or drowning, flooding, things like that, we're going to use whatever we have available to us. And if we can get the patient up off the ground, then we don't have to drag their weight across the ground, and we're not faced with the sort of problems of friction, and it's very, very tiring to drag someone any distance. And so we want to get them on something, and so we can use, really, the only limitation is your imagination. Just make sure that whatever you put them on is strong enough to support their weight, because the worst thing you want to have happen is it breaks halfway and the patient falls through onto whatever is down below them. So let's talk more about these cervical spinal immobilization. Now, I thought I was going to hit this during splinting, but it looks like we're going to cover it here right now. But we're going to practice this skill along with the splints. So anytime a patient has sustained a traumatic injury, any sort of traumatic injury, we want to consider the possibility for injury to the bones of their neck, right? And so that region of the neck is called the cervical spine. Your cervix is from the base of your skull to sort of in between your shoulder blades is where that cervical spine is. And so the worst case scenario is that there is an injury that is serious enough that the spinal cord that runs from your brain to the rest of your body gets pinched or severed. And if that's the case, if it's severed that high, then you're going to lose the ability to move your extremities. If it's high enough, you're going to lose the ability to breathe on your own. If anyone remembers the actor Christopher Reeves, who played Superman way, way back in the day, he had a horseback riding incident and he broke his spine very, very high up, and he spent the rest of his life on a ventilator because he lost the ability to control his own breathing. So that is the worst case scenario. Now, what happens more often than not is that people will injure the tissue around their spine, right? And so they'll have pain sort of off to the sides in the muscles of the neck, or sometimes they'll break off a piece of the spine called the It doesn't matter what it's called, but a piece of the spine that's not next to the spinal cord, and so they'll still have a broken bone there, but it's not something that's going to threaten the spinal cord. In any case, if they complain of neck pain, right, and specifically neck pain that is centered over where their spine is, which is the center of their neck and the back there. If they're complaining of pain that you think could be spinal in nature, then what we want to do is minimize the movement of their head and neck and consider the application of a cervical spinal immobilization device, or a C-collar. So how are we going to do this? Well, so the very first thing we're going to do is we're just going to tell them to keep their head and neck still. Now, like we talked about, most people who are experiencing neck pain are not going to move their neck, even if it has nothing to do with the bones of their neck. Anyone who is woken up with a stiff neck because they slept wrong and now they're moving their entire shoulders can attest to this. You don't want to move your neck, just as a general rule, and so you're pretty good there. The likelihood of someone sort of whipping their head around and breaking their own neck, very, very limited. There's some anecdotes out there, but there's no real data to support that. But as a reminder to them that they shouldn't move their head and neck, we can apply these rigid cervical collars. And these are really just used to prevent excess movement, right? They are not going to immobilize your head. You should not think of them as something that's going to immobilize the head and neck. They are simply a reminder to the patient. The soft collars that you see down here at the bottom, there's this, which I actually haven't seen in a long time. There's some donuts that you can get. They don't do a great job supporting, especially trauma patients. These are usually things that you'll get once you've made it through the healthcare system and they want to give you something on your way out of the hospital. So a lot of the collars that we use for trauma are going to look like the stiff collars in the top of the picture. And we're going to go over the specific directions for applying these collars when we run the skill. This very much is a physical skill. But generally speaking, when you apply it, you want to size it appropriately, and you want to size it in a way that allows the patient to be relatively comfortable and allows you to continue your physical assessments, right? And we'll dig into more of what that looks like when we practice this skill. So again, we don't immobilize people with backboards. Backboards are great lifting and moving device. They're great for getting people out of motor vehicle collisions and sort of sliding them out of the seat while maintaining that inline movement of the spine, but they absolutely should not be immobilized. Now, if you're going to carry someone on a backboard, they should be strapped into that backboard. So don't ever just throw someone on a board and start carrying them around. They will come with buckles and straps and all of that, and so you need to make sure that they are secured properly. But once they're on a stretcher, then oftentimes they will be immediately removed. And this is a skill that is done by EMTs, advanced EMTs, and paramedics. And some general rules of thumb. Again, we're moving the patient as a complete unit. So we're not going to drag them sideways. We're not going to drag them by one arm. We're going to try to move them all at the same time. Arms, legs, torso, head, all at the same time. Transport the patient face up, please. Don't flip your patient upside down just to see how good of a job you did strapping them in. That's a recipe for disaster. You will sometimes see people transported on their belly, but this is usually a critical care maneuver and is done as part of a host of respiratory techniques. So if you see a patient laying on a stretcher on their belly, then please ask questions because it is unusual and you want to learn as much as you can. But that is a transportation technique, but it's usually something reserved for medical patients in a critical care environment. All right, so log rolling. You know what? We've been at it for about an hour now. Let's take a short break before we get into log rolling. We're a little bit more than halfway through this slide deck. So let's take a short break and then we'll power through the rest of it. Come back in 10 minutes. So that's going to be 7:22-ish. All right. And you can go ahead and turn off your webcams and all that jazz. Recording again. All right. So log rolling. Log rolling refers to rolling the patient over on their side for two reasons. First reason is that you're going to assess the back, right? Because you can't get a good look at their back. You can't observe and feel for injuries if they're laying on it, right? So the first reason that we want to roll someone up is so that we can get a good sense for, do they have any big holes in their back, or, you know, does their spine go in a straight line, or does it, you know, poke out, or does anything poke in, fountains of blood, all sorts of things that we're looking for. The second reason why we'd log roll someone is that we need to put something underneath them so that we can lift them up and put them on the stretcher. And so in a lot of cases, the thing that you're going to put underneath them is a blanket. And so we log roll people in hospital beds, we log roll people on their living room floors, you know, all sorts of places that we would perform this. And then inevitably, after we assess, we'll put something underneath them and then roll them back over onto their back so that we can lift them up. And this is something that we're going to practice tomorrow. Now, you can use this to put someone on a backboard. But again, we don't immobilize people with backboards. We just move them from point A to point B and then put them on a stretcher. So the important part of log rolling is that it requires more than one person. And it requires a coordinated movement between all of the people involved. And so one person is generally going to be responsible for maintaining the patient's head in a neutral inline position. And so generally speaking, this person is going to be at the head, cradling the head and neck, and they're going to be the person making all of the calls. So they're going to say, is anyone not ready to roll? Okay, on my count, move on 3. 1, 2, 3. And then everyone moves very slowly, and the person with the head is going to, again, keep that head in a neutral position as they're rolled up on their side. Generally speaking, you want at least one, preferably 2 other people who are doing the rolling portion of things. And so they are going to grab the patient by whatever point is sturdy, so either by a belt buckle or waist fabric of pants, by shoulder or shirt or something like that, and then roll them up past the point of 90 degrees so that you can look down at the patient's back and visually assess, as well as use one of your hands to physically assess their back. And then when you roll them back down, after placing something underneath them, again, it's on the head person's count. So the person at the head is going to be, is anyone not ready to roll them? Okay, let's roll on my count on 3. 1, 2, 3. And then everyone gently moves them back down. Now here's a pro tip for you. And this is something that I picked up working in the Army Honor Guard, actually, where we do a lot of our sequences in a silent sort of manner. One of the things that we had to do a lot is we had to pick up caskets and things like that, and we have to do it all at the same time, otherwise it looks like garbage. And so one of the things that we learned that sort of hijacks the human psyche is that when you say things fast, people do things fast. So if you say 1, 2, 3, that patient's going to roll right up. And it's going to be a swift jerking motion, and it's probably not going to hurt the people rolling, it's probably going to hurt the patient. And people are just naturally going to do that. Whereas if the person on the head counts slower, 1, 2, 3, everyone's going to come up using the cadence of the head man. And so the patient's going to roll much more gently and much more slowly. And so this is an indicator of how you, as a trained rescuer, can come onto a chaotic scene And by using your training, you can bring calm and control to that emergency scene. And part of that is using your calm, control voice. Speak clearly, speak slowly, without hints of panic. And so part of that is just counting slowly. All right, so now let us move forward to straps and buckles. So any patient who is on any moving device needs to be strapped down. So whether this is a backboard or a stretcher or a stair chair, if they are secured to any sort of movement device, they need to be strapped in, period. So a lot of these devices will have straps mounted to them, but some will require that you buckle straps in or you add additional straps. Usually these things are made from the same material as seat belts or something similar. Usually they're pretty long to get around girthy patients. When you strap someone in, you want to make sure that you are securing all of the major weight centers of their body. So you want to make sure their legs aren't going to flop around. You want to make sure their arms aren't going to flop off the edge. And you want to make sure that there's at least something around their chest and their waist, because those are the areas that are prone to side-to-side movement and large areas of mass. Now, this picture is obviously showing something that we don't do anymore, which is use head blocks and straps and things like that. Because if the goal is to reduce movement of the neck, by securing the head and then having the body slide around, you're actually inducing a lot of motion into the neck, which is why we don't use those things anymore. But the other things that we see here are appropriate. So we see that the feet are secured. We see that they put a strap over the meaty part of the thighs. I'd like to see one around the waist if possible. And then notice how they put the strap over the chest to keep the arms in so that they're not flopping off and getting caught on door frames and stuff like that. We don't want to injure the patient while we're carrying them out of the house down a long hallway or something like that. We don't immobilize the head anymore. Good talk. All right, so let's summarize what we've learned. So someone asked in the chat, Dustin asks, do we now crisscross the straps? So I like to crisscross the straps. I think that's a great technique. And in fact, if you look at the Stryker stretchers, they have shoulder straps, like a 5-point racing harness system, where the straps come down over the shoulders. You have a set of straps that come up over the waist, and everything sort of buckles together. And then you have additional straps for the thighs and the legs. If you're using a backboard, I'm a big fan of the straps coming over the shoulders, crossing over the chest, and then linking down on either side, and then having an additional strap go across the waist. I think this is a really good way and a quick way to secure patients. But again, as long as the patient is secured to the board, isn't going to slide off, isn't going to hurt themselves, then it satisfies the objective. And the objectives are that we don't want to do any further harm to the patient, that we're moving this patient only when it is medically necessary, that we do it in as little movements as possible to, again, reduce the amount of harm that we're doing, that we're moving the patient as a whole body and not just part of their body at a time, that we're protecting ourselves by using good proper lifting and moving techniques, and that we are communicating with our team to make sure that no one is left unready to start moving this person. We learned that we can use a recovery position for unconscious patients who don't have any sort of ongoing medical or trauma care required for them. Again, this is usually used in a resource-limited environment. We learned that if a patient's on the floor during an emergency, then you can use several methods to get them out of the emergency situation into a more safe situation. We covered a little bit about spinal injury, and we're going to talk more about spinal injury when we get to the bones and muscles section as well. But generally speaking, we learned a little bit about spinal injury and spinal motion restrictions. We learned a little bit about wheeled stretchers and portable stretchers and stair chairs and scoop stretchers and all that good stuff. Anytime a person has sustained a traumatic injury, especially a traumatic injury to the head, neck, and spine, we want to just keep in the back of our minds all of the things that we can do to make sure that we don't cause additional injury to their spinal cord and spinal column. And so we have a few things that we can do. One of those is placing a cervical collar. And again, this is a physical skill that we're going to get into, I think, in week 3. All right, so let's do some review questions, and then we'll get into patient assessment. So as an EMR, you may injure your back even if it's straight if you lift with your back bent forward at the hips, if you align your shoulders over your hips, if you hold your hands close to your legs, if you use your leg muscles. What do people think?
Hey,
Hey.
Yeah, that's right. As Homer Simpson would say, lift with your back. Use quick twisting and jerking motions. Yep. If you lift with your back bent forward at the hips, you're definitely going to pull something in your low back and cause a workers' comp issue. All right. Number 2, patients who should be transported on a backboard include, and feel free to add option E here. Should we immobilize someone on a backboard who is intoxicated, someone who requests to be immobilized, someone who has an upper extremity injury, someone who has sustained a gunshot wound to the trunk, or E, none of the above? Honestly, like, none of these patients require a backboard.
Where does this question come from?
This question comes from Jones and Bartlett Learning, Limited Liability Corporation. They are based in Burlington, Massachusetts. They have been publishing these textbooks for tens of years and just making money hand and fist.
9 times out of 10, these patients can just walk themselves into an ambulance.
Yeah, so an intoxicated patient, I would say, usually they're capable of ambulating in most cases. If they're not, then we put them on the stretcher. It's often easier to put an intoxicated patient in a stair chair or a stretcher than try to manage them walking. And so oftentimes I'll ask them if they can stand up, move the stretcher in behind them, and then ask them to sit right down, and I'll wrap them up in a blanket. I don't think anyone would ever request being put on a backboard unless they were an EMT student. Upper extremity injuries, again, if their legs work, we can walk them to the ambulance. In a lot of cases, they only need to walk to the stretcher. We'll sit them down, strap them in, and then wheel them to the ambulance. And then someone who has sustained a gunshot wound to the trunk, we're going to learn more about chest injuries and bleeding control and things like that. There's always a chance that the bullet could have gone through and hit their spine, but honestly, you have bigger issues to worry about if that's the case. So while the slide deck has the answer as being D, really none of these patients require spinal immobilization of any kind. So, yep, I like everyone who answered E, none of the above. All right, head immobilization is not required in all patients who are placed on a backboard, can be achieved using head blocks or towel rolls, does not need to be maintained during the backboarding process, can be properly accomplished only with special equipment. Or E, this question doesn't make any sense, came from the 1990s and doesn't apply to the modern era.
Do you have on available like a set of example questions from the actual EMR registry?
No, the National Registry, there's surprisingly few test resources for EMR because it's a below entry-level certification. EMT is the entry level of EMS in most cases. And so you're going to find a lot of material for the EMT level. Now, that said, I suspect that you would be able to download an EMT test prep application or buy an EMT test prep book and be able to approach that material pretty easily without too much additional study. But there's not a whole lot out there for EMRs. The National Registry is not going to ask you questions like this. Spinal immobilization has been removed from medicine in large part. And so this is one of the only sections of these materials from the publisher that really just is out of touch with reality. So we're not going to have this problem for the rest of the course. So, yeah, this answer is dumb. The question is even dumber, and we're going to move on. So, any questions about everything that we just covered here? Not withstanding the spinal stuff. William is all caps. No questions. I feel you. Does anyone else have any questions about all this? All right, so I just gave you guys a break not too long ago. Let's dig into the first part of patient assessment, and then at around 8 o'clock I'll cut you guys on another break. But let's push right through for now. And if you have any questions, feel free to interrupt, come off mute, ask the question, drop it in the chat, and we'll go from there. All right, so we're skipping all the way from chapter 3 to chapter 9. And why do I skip around the book like this? So last class we went from chapter 1 to chapter 21 in a straight line. And because patient assessment is chapter 9, they didn't get it exposed to putting their hands on a patient and starting to do the process of medical care until the second or third week, which in a 5-week course, that puts you at a huge disadvantage. And so one of the big things that we changed was we put these chapters in the order that you need to know them in order to build the skills that you'll need to be an effective EMR. And so now we're jumping all the way up to chapter 9. We're going to talk about patient assessment, and then tomorrow morning, you guys are going to put your hands on patients. You guys are going to start doing these patient assessments and really lay the foundation of everything else that we do in emergency medicine. And so this is really the bread and butter of this course. So take notes. We're recording this. It's going to be up on YouTube. You guys can go back and watch the lecture again. But this is really important stuff. So let's dig into it. So you'll find these standards under the assessment section of the education standards on ems.gov. And so we're going to talk a little bit about scene size up and sort of looking for the dangers that may be present on scene. We're going to talk about the primary assessment, which is our initial search for life-threatening conditions and interventions for life-threatening conditions. We're going to dig into history taking, which is talking with your patient and determining what their medical conditions and what the history of the present illness may be. And then we're going to get into a secondary assessment, which is a more thorough, focused assessment. And then finally, we're going to talk about reassessment, because this is not a series of checkboxes, even though that's what it looks like on your skill sheet. This is a continual process that we're going to do until we hand these patients off to a qualified medical provider. So one of the things that I hope that you picked up from Wednesday's lecture with Dave is that as EMRs, really the intent of the EMR, the emergency medical responder, is that you are going to be in the community. So these are police officers, these are ski patrollers, these are fast squads, so EMS agencies that respond in a non-transporting ambulance. And you're going to be the first medically trained people on scene a lot of the time. right? And so an old surgeon, an old military surgeon that has a famous saying that the fate of the wounded rests with the person who applies the first bandage, right? And he was talking about war wounds and trauma. But what we've seen over the intervening 200 years since he said that is that it's really true. The first person to put their hands on an injured or sick patient often has the biggest and an outsized impact on the outcome of that patient. And so you guys are really in a great position to do the first initial steps of life-saving care so that the patient is still viable when the paramedics show up, so that the patient is still viable when they arrive at the hospital. Because there's nothing that the best trauma surgeon in the world is going to do for a dead patient on their operating room table.
It's in the bedroom.
All right. Thanks for that, Alexis. Appreciate it. So let's see if I can. All right, Alexis is now muted. All right, so your assessment of the scene and the patient will affect the level of care that is ultimately delivered to this patient. So your assessment is going to determine whether advanced life support is called. Your assessment is going to find, the life-threatening conditions. You're going to stop the patient from bleeding out. You're going to open the airway so they don't suffocate. You are really going to do the initial life-saving steps that's going to either save the patient's life or not. And everything else that gets done later down the road is just sort of making things better. But you're going to save the life. And you do this through a process, a 5-step process of patient assessment. So it's important that you're able to perform this sort of systematic patient assessment to determine whether your patient has a medical condition or has suffered injuries from trauma or what have you. Now, I like to say this to my students. This is really, really, really important, all right? If you want to be successful in this course, I don't care what system you use to accomplish these tasks. All right. I have a system for you. I'm giving you this system, but I don't care what system you use as long as you have a system and you use it every single time. All right. You need to have a system. You need to have a systematic approach to patient assessment and care, and you need to use that system with every single patient. Never deviate, never skip steps. All right. The minute you start skipping steps is the moment you start missing things, and you'll miss important bits of information that really make or break your diagnosis. And you're going to see this because inevitably you're going to skip a step, and you're going to see this when we start getting into scenarios on Saturday skill sessions. You're going to get out of order. You're not going to ask a question. You're going to miss an important bit of information that will say, oh, of course, I know what this person is suffering from and I know how to treat it. But if you don't follow this system, you're not going to find the information that you need. So the 5 steps that we have here, our first step is a scene size up, right? And this is before you touch the patient. The second step is what we call the primary assessment. And this is a very, very quick, rapid assessment of the patient's life threats, right? In a lot of cases, the primary assessment can be done in the time you can hold your breath, right? So this is a 30 to 40 second, very quick airway breathing circulation type assessment. This is a very similar assessment as you learned in your CPR classes, where we're checking for responsiveness, we're opening the airway, we're checking to see if they're breathing, we're checking to see if they have a pulse. That's your primary assessment. Now we're gonna open that up a little bit, and we're gonna give you more information and more tools, but that's what it is. Very, very quick. From there, we're either going to get into a history-taking approach, which is asking questions, or we're going to get into a secondary assessment of the specific problem they have, or if they're unconscious, a general head-to-toe systematic survey of their body, right? And we'll get into when you perform which one. And then once we're done with all of that, So we've taken their history, we've assessed their entire body, we've gotten a set of vital signs. Then we're going to get into reassessment, which is going back and looking at all of our interventions, retaking vital signs, and all of that. So we're going to go through each one of these steps, but this is the system that I want you to use, and you're going to use it every single time. So the skills and knowledge presented in this chapter in your book and during this presentation are your assessment-based care model, is what it's referred to as. With assessment-based care, the treatment that you give is based on the findings of your assessment. So you're going to perform this systematic assessment. You're going to determine that there's a problem. You're going to provide a treatment for the problem that you found, and then you're going to go back and reassess to see if your treatment was successful. So it's a very systematic cycle of assess, treat, reassess. So Dustin's asking, how in depth does the history go? And we're going to talk about taking a medical history. We're going to go through all of the other steps first, but I'm going to give you a mnemonic or a memory aid to hit all of the steps, and then you'll have ample opportunity to practice that throughout the course. So patient assessment sequence, again, we want to start off with scene safety. And so there's a bunch of steps when it comes to surveying the scene. And the very first one is determining what the dangers on scene are. Now, in a lot of EMS classes, they'll just have you sort of slap your hands together to simulate gloves, slap, scene safe, and you just sort of move on from there. But scene safety is not a box to check. It is not something that you're going to assess for once and then forget about. Scene safety is a continuous survey of potential danger and an active mitigation of that danger. You're going to be constantly looking around for things that will potentially be hazards to you, and you're going to continuously position yourself in a position of advantage so that you can either render effective care or escape any dangers that may be happening. So constantly be assessing an emergency scene for hazards as they appear, because a hazard that may not have been there when you first arrived on scene may become apparent later. You're also going to determine the need for additional help. And so, again, this is if you see, a scene that is obviously outside your ability to provide care, a rescue scene, a scene with extra patients, a scene with a motor vehicle extrication or a house fire, something like that. You need to get the appropriate resources on their way as soon as you can, especially if you're in a rural environment and it's going to be 10, 15, 20 minutes before the engine shows up with, 3 or 4 extra people. This is also your time to determine if this is an illness or an injury, and you're going to determine the number of patients, again, mechanism of injury, nature of illness, so on and so forth. And that's going to be the extent of your scene size up. All right. Some other things that you want to take into consideration when you're responding to the call, just sort of things that you're thinking about en route to wherever you're going. What time of day is it? What are day of the week? So, for example, weekends and holidays versus work days. What are the weather conditions outside? And this way you can mentally prepare for the situation that you're going to find on scene. So I'll give you an example. I was called out for a car versus tree on the highway, right? On a stretch of 93 that I covered at this station. And so not unusual. I mean, this stretch of 93 on a snowy day will easily get 7 cars off the road, and 6 of them will be sign-offs because they weren't injured. Their cars all crumpled up, but they're fine. But this particular day, it was the middle of summer. It was not raining. It hadn't rained. The pavement was dry, and it was sort of 8, 9 o'clock at night. And the location was a long straightaway, wasn't curvy. So already on the way to this call, because I knew my coverage area and I considered the time of day of the week, it was an average weekday. Weather conditions were clear, and I knew it was on a straightaway, that this was probably not going to be a sign-off. And indeed, we arrived on scene, and it was just a horrific accident. But we had already spun up additional resources for vehicle extrication. And we ended up calling the helicopter for one of the patients. And so when you mentally prepare yourself for that sort of scene, it sort of primes your decision-making processes to get the right resources, to be looking out for extra patients in case there were ejections from the vehicle and things like that. When we arrive on scene, in a lot of cases we want to, in the ambulance anyway, the ambulance doesn't make a great blockade for traffic because it's basically just a big fiberglass box. So if we can get a fire engine between us and traffic, that's awesome. But again, because of who we are and where we work, we may not have that fire engine. And so sometimes parking our response vehicle with the lights on and everything else between oncoming traffic and the accident scene will minimize the chance that someone is going to drive through our accident scene going 60 miles an hour and potentially cause more damage. So we want to initially scan the scene, determine the best place to park our vehicle, and you'll get more of this when you go through emergency vehicle operator course and other courses like that. So we're looking for visible hazards, and so the witty acronym or the witty mnemonic that I like to give people is you arrive on scene, and the first thing you say to yourself is WTF, which stands for wires, tires, and fires. We want to be, those are the common things that we see on scene. These are power wires down across the road or across the vehicle, inflated tires on cars. So cars with tires will roll. That's what they're designed to do. So if we can put the car in park, if we can pull the emergency brake, if we can let the air out of the tire so it doesn't roll as easily, it makes a safer scene for us. And then, of course, fires or the threat of fires. So spilled fuel or anything that's a running engine. So if the car is still running, things like that, that presents a potential hazard for us. And there's also other things that we want to be aware of. So gathered crowds, especially one of the incidents that I point to is, we are currently healthcare heroes. But there was a time earlier on during the protests that broke out after the murder of George Floyd. We were seeing fire trucks and ambulances stopped in the middle of the road on their ways to medical calls and burning buildings. And, crowds were smashing in the windows. They, in some cases, pulled the responders out of the vehicles, and it was just a bad scene. And of course, that represents a worst case scenario and is really in the body of all evidence an anecdote. But crowds in general can interfere with transport. They can block emergency vehicles from accessing the scene. They can attempt to help and really be sort of obstructive or even cause harm. And so we want to make sure that we're controlling crowds. And the same with weather. Mother Nature always gets a vote in everything that we do. In fact, Mother Nature is often the cause of what we do. So just take that into consideration when we're talking about unstable surfaces, ice, water, things like that. And then part of the requirements for this course is that you take the AWR 160 through the Texas A&M Extension, and that's going to talk about biohazards and some hazardous materials and sort of weaponized radiological material and stuff like that. And so you'll get ample exposure to those sorts of threats. So we talked about mechanism of injury and nature of illness. So before we dig into this more clinical stuff, does anyone have any questions about scene safety? Has anyone ever responded to a scene that was unsafe and want to share that with us?
Yes, we have scenes where drug overdose, where you are not allowed to approach the patient until police units are there and to check out the scene before you go in.
And why do you think that is?
A lot of the times, the patient becomes very violent when you Narcan them. They tend to strike punches and get a little upset. So,
And that's a really good point. And we're going to bring that up again during toxicology, because there is a reason why patients wake up like that after you give them Narcan. And most of the time, with few exceptions, most of the time it's because we are doing it wrong and we're doing it in the wrong order. And so we're going to talk more about that, because I dealt with a lot of opioid overdoses here in Manchester, and there's a very distinct difference between opening the airway and providing oxygen and then reversing the toxin versus reversing the toxin and waiting for them to open their own airway and having them wake up with, in a hypoxic state and being disoriented and agitated. And so we're going to dig into that quite a bit. But that is a good example. So that's an example of what I would call iatrogenic scene danger, which is a fancy term for induced by the provider. Our actions are actually making that scene unsafe. Bernard, you dropped a yes in the comments there. Do you want to share your unsafe scene?
Yeah, can you hear me?
Yes, I can.
Good. Okay. So, about a week ago, we got a response, and so they knew that I'm taking this class as well as having my BLS, and we responded to CPR in progress, where unfortunately, despite our best efforts, did not survive. Got a call back to that house a day later for a second one of the significant other tried to commit suicide with alcohol. The problem was the family had already been on the scene as we were getting there. And as we were all walking in, they were all obviously distraught because of the loss they already had that week. But alcohol had been a situation. And of course, everybody wanted to know questions right then and there, where what we were trying to do was respond to the patient and get the supplies in we needed from the ambulance and everything, which thank God we have Bethlehem Police Department is very close with us, and they were there to secure the scene for us and keep the disgruntled family away, who was trying to backseat do everything.
What was the danger? What was the specific danger?
Them starting to come over us and get hostile towards us, started yelling and trying to just get involved. And once somebody starts getting in and starts crashing your area while you're trying to get at somebody, that can become bad.
Yeah, that sounds like a pretty chaotic scene.
But lucky for us, the police grabbed control right away and removed everybody.
And that's good. That goes back to the crowd, right? Managing the crowd effectively. That's good.
Correct. But
and a lot of that
scene size up too. Like you said, you always have to be aware of your scene regardless. Keep an eye on everything happening around you. Just because you secure it at one time doesn't mean something isn't, coming up from behind you while you're focusing in on that patient.
Mm-hmm. Absolutely. And that's why I want everyone in this class, when you start a station or a scenario, don't just clap your hands together and say, scene safety, or is the scene safe, right? Because that's not something that you can determine. You have to instead put on your gloves, and while you're doing that, what are the dangers on the scene? Not are there any, what are they? And be constantly vigilant. So those are two really great examples. So what I'm going to do now is I'm going to cut you guys out, give you another 10-minute break. So come back here at 8:05, and we'll dig into the rest of patient assessment. All right. So in the next few slides, we're going to cover some key terms. And we're going to start off with the terms mechanism of injury and nature of illness. And this is often referred to as MOI for mechanism of injury or NOI for nature of illness. Although, just be warned, those two things sound very, very similar over the radio. So we'll use terms like mechanism as an abbreviation for mechanism of injury. And so what does this tell us? Well, mechanism of injury gives us clues as to what may be wrong with the patient. So if we are responding to a motor vehicle accident, there are certain things that we're concerned about happening to the patient, right? We would expect that if the airbag went off that they would have facial trauma. We would expect that if they were wearing their seatbelt, they may have chest trauma. And we would expect that if they weren't wearing their seatbelt and they didn't have an airbag, significant chest trauma or ejection from the vehicle, right? And so these are all things that are sort of running through our mind based on the mechanical forces at play. And then the same with nature of illness. If we're responding to someone who has difficulty breathing or shortness of breath, then we're going to use our knowledge of anatomy and physiology, we're going to use our medical knowledge of respiratory complaints, and we're going to start coming up with a list of things that could potentially cause shortness of breath. And they're not all related to the lungs. And so by thinking about these things, we can prime our decision making to make sure that we're doing the right things quickly once we arrive on scene. Now, the danger of this is something called premature closure, which is you receive information from dispatch, like please respond to 123 Any Street for a report of a stroke. And you arrive on scene and you've been handed the diagnosis of stroke by someone who just talked to someone on the phone, right? They don't know what's going on. And you walk in and you start doing a stroke assessment and you start doing all these other things that are targeted towards this one diagnosis, but you haven't taken an appropriate assessment of the patient. You didn't realize that it's not a stroke, it's actually a heart attack, or it's actually a diabetic crisis, or something else that can cause altered mental status. And so you need to be cognizant of our natural tendency to lock on to the first thing that we think of when we get into a situation. And that's why we use systematic methods of assessment, so that we make sure that we don't miss things and we don't lock on to clues that don't actually give us meaningful information. And so the mechanism of injury doesn't determine what we are going to do. We don't treat based on the mechanism of injury. We allow the mechanism of injury to raise our index of suspicion for certain complaints while we're doing a thorough assessment. And that's really the meat and potatoes of this slide. So the next term that I want you to know about is what we call standard precautions. And there's a lot of other terms that sort of fall under here. Body substance isolation is a common term that is used throughout EMS. Sometimes that's abbreviated as BSI. But what standard precautions refers to is a general set of precautions that you take to prevent the spread of infectious diseases. And so the first thing that you should think of is gloves, right? We always put on gloves before we touch patients. Now, you'll go into a doctor's office or something like that, and you'll see doctors not wearing gloves while they're assessing their patients. And this is because they're doing these assessments in controlled environments, and these patients aren't bleeding. They're not, vomiting all over the place. Whereas we generally go into uncontrolled environments with patients that we don't know well. And so this is why we're always going to wear gloves before we start assessing people. Now, there are additional levels of precaution that we want to take. 1 second. There we go. Got to contain the recording studio here. There's other levels of precaution that we may want to take. So, for example, when I was riding on the ambulance, I always tried to wear a pair of clear eyeglasses, right? Because you never know when someone is going to cough a big loogie right into your eyeball. And I can tell you from personal experience that blood and spit are not things you want dripping off your eyeballs. Also, especially when you are performing procedures that generate aerosolized saliva. For example, when you manage an airway or when you're using a bag valve mask, these take the patient's breath and turn them into a plume around where your head is working. And so you want to wear eyeglasses or safety glasses while you're doing those procedures. The same thing with bleeding control. You don't want blood splashed in your eyes, nose, or mouth. And then another thing that we're probably all very familiar with is face coverings like surgical masks or respirators like N95s. And these are an additional layer of protection that you can wear to either protect the patient from you or to protect you from the patient. Yeah, you from the patient. So, for example, when I worked in an operating room, we wore cloth masks because our breath had the highest chance of contaminating the open surgical field of the patient. And then when we're in the back of the ambulance and someone has an infectious respiratory disease, wearing a respirator like an N95 mask protects us from what the patient is breathing out. And so all of these things have time and place for their use based on your assessment of the risk of infectious disease exposure. All right, so next we're looking at number of patients. And so a lot of people would think that this would be obvious. You know, you are being called to a scene for a person calling for help, but sometimes it is not obvious. And sometimes the patient that you think you're responding to is not the patient that actually needs help. Or sometimes you arrive and you find the patient that called for help, but you also see extra patients, you know, family and bystanders and things like that that need additional assistance or additional support. And so always keep in mind that the number of patients, the number that you get over the radio may not be the number that you find when you're on scene. And then, like we said before, always consider additional resources. These resources aren't always medical in nature. So, for example, we arrive on scene. We're looking for wires, tires, and fires. If we find wires, tires, and fires are dangers, so we see that the power lines are down, we see that there's something on fire nearby, well, as EMS personnel, we're not going to mess around with charged electricity, and we're not going to pull out our little fire extinguisher and try to put out a car fire. There are specialized workers for this. We have fire departments, utility companies, we have people who are going to clear the vehicle off the road. And so we need to get those additional resources en route as soon as possible so that we can clear the scene and leave it in a condition that works for society. All right, and now we want to talk about life threats. So life threats is a big deal here, and our primary assessment focuses on life threats. Now, the purpose of the primary assessment is to quickly identify things that are going to kill the patient within a matter of minutes. These life threats are related to problems with airway, breathing, and circulation. And so, put another way, bleeding out and suffocating. Those are the things that we're really concerned about. It's important to identify these life-threatening conditions as quickly as possible because we want to take immediate actions to correct these conditions. So for our general impression, right? So a general impression is going to be your assessment of the patient before you actually touch them. So we want to initially note the patient's. So we have a question in the chat. Depending on the area you're in, would you call dispatch to get others to help or radio them yourself? So dispatch is your central clearinghouse, and we'll talk more about this during the communications section. But the relatively low-powered radios that you have on on your truck and the portable radios that you carry around. Generally speaking, you're going to be calling back to dispatch, and dispatch will be able to reliably get the resources to you. Just because either the resources are not on the same radio network as you, or you just don't have the range and power in order to contact them directly. So, and we'll talk more about that when we get to communications. So forming a general impression, this is before we touch the patient. We're looking at the patient's apparent sex, approximate age, body size, and just physical characteristics of this patient. You're also going to determine whether this is a traumatic injury, a medical problem or illness, or a combination of the two, because they could have always gotten sick and then been traumatized, or had trauma exacerbate an illness. We're going to determine their level of consciousness. And so when you were going through your CPR course, you all should have been, hey, are you okay? Tap the shoulders, yell as loud as you can. We're doing the same thing. We're going to add a few more steps to that, but we're going to determine, generally speaking, what the patient's level of consciousness is. And then, again, we're talking about premature closure here. Don't let your initial impression of the patient block out later information that you may gather through assessment. All right. We always want to be open to new information so that we can change our idea of what's going on or add to our idea of what's going on. So when you assess level of responsiveness, the best way and the most common way to do this is you walk up to the patient, you introduce yourself. Hey, my name is Max. I'm an emergency medical responder with the local ambulance. Here to help you out. What seems to be going on today, right? And this does a number of things. First, it establishes rapport with your patient. You're introducing yourself as a professional rescuer and all that important professional stuff. Second thing you're doing is you're determining their level of responsiveness. Do they look at you when you talk to them? Do their eyes follow your movements? And you can gain a lot of information. If they respond, hi, Max, my name is Sally. I seem to have chopped my arm off with a chainsaw, and golly, does it hurt. Now we know that their airway is open because they're forming full sentences, right? They're speaking without difficulty. Also maybe on some substances in this case. And so this gets us a bit of information about them. And then third, you're gaining consent. And so we're going to talk a little bit about what consent is when we talk about medical, legal, and ethical considerations next week, I believe. But you're checking a bunch of boxes all at the same time by introducing yourself. Now, what I'd like to do is ask the patient's name and then use the patient's name when you're talking with them. Also, if it's not an emergency, if you don't see any life threats, if they're not bleeding out, they're not on fire or underwater, they can speak in full sentences, they don't appear to be very, very sick, you can talk with their family as well. Hey, Sally, who's this you got here with you? And they can be a valuable source of information as well, especially if you determine if the patient has an altered level of mental status later on. So sometimes you'll introduce yourself and the patient appears to be unconscious, right? Just because they appear to be unconscious doesn't mean you should change the way that you talk to them, right? It obviously changes your level of concern about what's going on with the patient. But a lot of times, patients who are unconscious may still be able to hear you. Your sense of hearing is the last thing that goes as you lose consciousness. And so there are a lot of people who have had heart attacks or who have had conditions that render them sort of unconscious to our assessment, but who can recall every word said during an emergency transport and resuscitation, and then come back and the EMS providers and emergency medicine providers have been taken to court over the things that they've said and all sorts of badness. So we want to remain the professionals that we are while we're treating this patient, regardless of whether they appear conscious or not. So if the patient doesn't appear conscious, gently touch them. You can shake their shoulder to see if you can generate a response. If they open their eyes while you talk, that's a good sign. It's not alert, but it's still good. If you can get a groan or a moan out of them when you induce a slightly obnoxious stimuli, then they'll be responsive to painful stimuli. But again, we don't want to cause pain and suffering to our patients just to determine if they're awake or not. And that will give us a general scale. We'll place them on a scale of alert to unconscious. And so when we describe someone's level of responsiveness, we use this AVPU scale. And it stands for alert, verbal, painful, and unresponsive. And this is what they are responsive to. So again, if I walk in and they're speaking to me, they're following me with their eyes, then I would consider that person to be alert. If I walk in and they're not really moving around and I call their name or I speak to them and they open their eyes, then they are responsive to verbal stimuli. They're responsive to me only when I speak to them. If they're not, if they don't respond when I speak to them, I can induce some kind of obnoxious stimuli. And so I'm sure you've all heard of lots of different ways to induce pain in someone to get them to respond. The challenge here is not to see all the fun and interesting ways you can make someone suffer. The challenge here is, are they responsive when you produce some sort of noxious stimuli? And in general, what we like to do is the sternal rub, right? Because pretty much anyone can suffer a sternal rub, and you're not going to cause a lot of damage. Pinching of the skin, putting a thumb across their fingernail, twisting on their earlobes, finding pressure points and things like that. We're not trying to hurt them. We're trying to see if they're responsive, and there's lots of ways to do that without causing unnecessary pain. And so what I am going to teach you during this course is the sternal rub. And so all you have to do a sternal rub is place the tips of your knuckles on the sternum, press down gently, and just rub up and down. And you can do it to yourself. It is obnoxious for sure, but it isn't overly painful and it's not going to cause a significant harm to the patient. All right. So once we've done all of this, so we've formed a general impression, we've considered cervical spinal immobilization, we've assessed for the presence of life-threatening conditions, such as life-threatening bleeding or the patient being on fire or drowning, right? We've determined our level of responsiveness. That's all part of this sort of general impression that we are forming. Once we've done that, then we are going to enter our primary survey. And again, a primary survey should be able to be performed in a single breath hold. The only thing you're doing is determining airway, breathing, and circulation. So let's start with A and ABC. So we're going to assess the airway. If the patient's alert and able to answer questions without difficulty, bam, you're done. Bob's your uncle, the airway is open. In an unconscious patient, you have to open the airway using a maneuver such as the head tilt chin lift, or if you suspect that there is spinal injury, we can do something called a jaw thrust, and I'll demonstrate what those look like when we get into the classroom on Saturday. Once the airway is open, you want to inspect it for any foreign bodies. Foreign bodies could be something large stuck in their airway. It could be their teeth that were broken off by trauma. It could be a piece of their tongue that they bit off. We're just inspecting for any foreign bodies or secretions, blood, vomit, things like that. If the airway needs to be cleared, then there's some maneuvers that you can use to clear the airway. So if you can see the object and you can reach it, all you need to do is dig in there with a finger and sweep it out. We don't do blind finger sweeps. We don't just stick our fingers in someone's airway because we think it may be obstructed. But if you can see the object and you can reach it, go in there, grab the object. If their mouth is full of blood or vomit or other secretions, then we're going to use a suction apparatus to go in there and suck out all of the secretions. After that, once the airway is open, then we need to hold it open. And we'll hold it open by inserting basic airway adjuncts. Again, we'll go over these skills when we get into the lab. So we've assessed and we've managed A. Next thing we're going to do is assess and manage B. So B stands for breathing. When we assess breathing, we're looking at the rate and quality of the patient's breathing. And now by rate, I'm not talking about stopping and counting their breaths in a given minute. We're looking for a very quick assessment of is it too fast, is it too slow, or are they not breathing at all? That's all we're looking for. And then what is the quality of the patient's breathing? So they may be breathing fast, but is it fast and deep or is it fast and shallow? Both of those represent problems, but they're different problems. So we want to know, is their breathing deep or shallow? Is the breathing fast or slow? That's what we refer to when we assess rate and quality. If the patient's unconscious, then we use what's called the look, listen, and feel approach. If the patient's having difficulty breathing, or if you hear unusual sounds, that's when we're going to want to check for an object in the patient's mouth and remove it if we can see it. If we can't detect any movement of the chest and we have no sounds of air coming from the nose or mouth, then we assume that breathing is absent. We want to take immediate steps to open the patient's airway and perform rescue breathing if they're not breathing effectively. And if trauma is suspected, we want to protect the cervical spine by trying to keep the patient's head and neck in a neutral position. And we can do that by using the jaw thrust maneuver, which again will be demonstrated tomorrow. So we have managed and we've assessed and managed airway. We've assessed and managed breathing. Now we're going to assess and manage circulation. So if the patient's unconscious, we want to check for a pulse. The easiest place to check for a pulse is the carotid artery. The carotid artery is one of the major arteries in your neck. You have one on each side of your neck in the front. In order to find the carotid artery, we usually place our index and middle fingers together. We start in the middle of the neck and we slide over towards the divot between the windpipe in the center and the big muscle on the side of the neck, right? When we slide our two fingers off the larynx towards the patient's ear until you feel that notch, then you should find the carotid pulse within about 5 seconds. If the patient is conscious, you can assess the radial pulse. And when the radial pulse is in the wrist. And to find the radial pulse, again, you take your index and middle fingers on the wrist at the thumb side. You'll find that there is a bone by the thumb. You slide it towards the center of the wrist and you find a notch there in between the bone and the tendons that move your fingers around. And in that little groove, you should find your radial pulse. And so here's some pictures. Now, what I'd like you to notice about checking the carotid pulse is that this person is checking the pulse on the side of the neck that they're sitting on. Imagine what it would look like if you were reaching across the patient's neck to assess the pulse on the other side. It would look like you're trying to throttle the guy. Don't look like you're trying to choke your patient when you assess the pulse. Not only does it look bad, but the position of your fingers across the larynx are actually preventing your fingers from getting down in that groove. And it's going to be more difficult for you to find that carotid pulse, especially on necks that are larger in size. So place your fingers on the center of their neck and then sweep over towards you into that notch to find the carotid pulse. And then the same thing with the wrist. When you assess for the pulse, I see a lot of people sort of slapping their fingers in the middle of the wrist. You don't have an artery in the middle of your wrist. The artery is on the outside of the wrist. So you want to start from the bone on the outside next to your thumb and move in until you feel that notch. And that's where you're going to find the artery. You can feel a pulse anytime an artery is compressed against a bone. So there's lots of places where you can feel arteries or feel pulses in the body. But the two that we're going to teach you are up in the neck in the carotid and down in the wrist in the radial. So once we find a pulse, once we've determined that there is a pulse, then we're going to look at the skin. And we're going to look at skin color, temperature, and condition. And so for skin color, and this is a topic in medicine that is sort of being expanded because every human is a slightly different color based on the amount and type of pigment in their skin. And so a lot of these things are going to look slightly different depending on, again, the amount and type of pigment in your skin. And so there's two different types, there's two different colors of pigment. There's a brownish color and there's a blackish color. And then how much you have of each and both will determine what does blood look like underneath your skin. What does the absence of blood look like under your skin? If you have an increase in liver enzymes, what does that yellowness look like under your skin? And the darker your skin color, the less you'll be able to rely on the surface of the skin, and the more you'll have to look at mucous membranes like the inside of the mouth or the beds of the fingernails or the whites of the eyes. And so in general, if the patient has a pale appearance, so in someone that looks like me, where like the most amount of melanin I have in my skin is confined to freckles, and the rest of me is as pale as porcelain, you're going to see me turn very white and pale. Whereas someone who has a much darker skin color, they may appear gray. And you may have to look at the inside of their mouth, their tongue, their eyes, or their nail beds in order to see the pallor that goes along with a condition like shock. The same with flushed skin. So on a sunny day, all it takes is me walking across the parking lot to get first-degree sunburns, and I have two colors, porcelain and lobster, and I make the transition very quickly. And so it's going to be very apparent in someone with my skin tone when I get reddish. However, those sorts of first-degree sunburns or even second-degree burns, responses to medicines, allergic reactions, and other reasons why someone's skin would become reddish are going to be very difficult to pick out in someone with a dark brown or dark black skin tone. And so again, in these cases, we're going to have to be looking for alternate signs on skin exam. Same with blueness. So we also refer to this as cyanosis. I would look very blue, but you may have to look at, again, the inside of the mouth, the beds of the nails, and the area around the eyes to see that bluish tint when they have a lack of oxygen. And then the yellowness, you'll see it in the whites of the eyes when it's very advanced, but sometimes you'll have to look at the palms of the hands and other areas in order to see that yellowness. And so these are all colors that the body can take that that will give you an indication of an underlying medical or traumatic condition, and these are all very important things to look for. And so we've now gone through airway, breathing, and circulation. And we didn't talk about how to treat for circulation because we have a section on shock and managing shock and bleeding control and all that. So we'll get to that. But we've gone through our ABCs and we've assessed and managed all of these conditions. The next thing we want to do is think of it as D. Right? A, B, C, D. This is our decision to transport or updating dispatch, right? It's really, really important that we update responding units as to what we found and what we did for the patient. And when we talk about communication, I'm going to give you some tips and some tricks on how to communicate this. But your very next step is to either get this person in the ambulance. If they need to be transported, if there's an ambulance available, we want to get them in the ambulance. Or if there's not an ambulance available, we want to update dispatch and thus the responding ambulance with the information that we've gained. All right, so any questions on primary assessment? All right, so Bill put in the chat that you use D right away on a call. Can you describe what you're talking about?
Yeah, had a 87-year-old male down for about at least an hour. We don't know full time. And on my doorway assessment, my lieutenant basically told me I was running the show. I got into the doorway and I hollered ALS right away because I knew I was going to need advanced life support because of the fact that he'd been down for almost an hour. We didn't know what was going on. I had Roth on him, and so we just started CPR right away and just kept going.
Okay, so it sounds like so what you did was you called for additional resources, which is part of the scene size up. Whereas when you finish your primary assessment, that sort of updating of dispatch is once you've completed your primary assessment, you've done your ABC survey, you've found and treated any life threats. At that point, you have a lot of information that you can then pass on to dispatch. And so, for example, you came on scene, you found someone who was unresponsive without, signs of life, and you knew that this was going to be a code that you were going to work, and that potentially there weren't the right people on scene to determine whether they should initiate CPR or not, right? And we'll get into what that looks like in a different lecture. So you determined that you needed to do CPR. You notified dispatch that we're going to perform CPR. We need additional resources here, right? Start the timer or whatever it is that the agreement that you have with dispatch.
Yeah,
at some point, go ahead.
We had Lieutenant on scene who was an A, but he was running the overall show, and I had enough support with me to perform CPR and so forth, but we just knew at that point that like I said, we had Roth on him, so we were able to keep some kind of a pulse.
Is Roth an automatic CPR device?
He had slight rhythm.
What is Roth?
Roth, or basically it's when you can feel a pulse to some extent that you can still work with the patient.
I'm not familiar with that term.
But we wound up working him, and I hadn't even gotten physically to him to check ABCs yet. So I just knew we were less than 10 minutes between door to door, from door to ambulance and on the road back out to the hospital. So it was that quick of a call.
Interesting. Okay. Yeah, and that's a great example of calling for additional resources. So that would be a little bit different than updating dispatch, but it's a good example of getting additional resources on scene. So that's good. Any other questions about the primary survey? All right, and you guys are going to get a lot of practice with this. You are going to be doing this again and again and again for every patient scenario that we do for the next 5 weeks. So you guys are going to get a lot of practice putting this into use. So once your primary survey is done, then depending on what's going on with the patient, whether they're a medical or a trauma call, you're either going to start taking a medical history, or you're going to launch into a physical exam of the patient. And so I'm going to talk about history taking now, because we'll put this in the context of the medical patient, which is overwhelmingly the type of patient that you're going to respond to in today's EMS system. But just know that when we start talking about trauma, that generally for a trauma patient, we're going to do a physical exam before we start asking questions about their history. So talking about history, we want to determine what the patient's chief complaint is, right? So if the patient is conscious and is able to talk, then investigating the chief complaint is relatively easy, because we can just ask them, what seems to be going on today? Why did you call 911 today, right? And then we can ask them a series of questions to get more information. If an unconscious patient, or if we're called to an unconscious patient, what do you think are the ways that we're going to get a medical history out of this person if they can't talk?
Maybe family member or if they have some type of like medical device on them, like a tag maybe?
Absolutely. So we have someone said bystanders, family members, absolutely. And this is a great use for additional personnel on scene. So if you have, if the EMT or advanced EMT, if they're sort of taking lead on the call, you can go check out the med list on the patient's refrigerator. You can be looking around for medicine bottles or cover sheets from their last doctor's appointment, or talking to family members about their medical history, right? So there's a lot of additional resources that are already on scene that you can tap into for the purposes of obtaining a medical history. So why do we want to gather medical history? Why is that important? So there's 3 reasons why we want to ask these questions. First is I'm going to give you a systematic method of collecting this information, something called a sample history, and we'll get into what that means in just a little bit. But we want to use this systematic method of gathering the patient's past medical conditions, illnesses, injuries, and things like that. We also want to get a general sense of how things played out. What events led up to the present situation, whether that's the accident that led to the injury or the progression of an illness. And then we want to determine the signs and symptoms of what is happening right now. What can we objectively measure? What is the patient experiencing? And we're going to write all this down and report it to other medical professionals. So when we ask these questions, we want to make sure that we ask them in a clear and systematic manner. The moment you start jumping around the sample history, if you ask M and then you go back up to A and then you ask E and then you hit P somewhere in there, you're going to inevitably skip things. You're going to miss questions and miss points of data. So it's important to ask them in a systematic manner. You also want to ask them in a clear manner. So there's a lot of things that we're going to ask the patient that we're going to remember it using medical terminology, but we need to ask the patient in language that they can understand, right? So, when we ask something like allergies, right, they may give us a whole bunch of stuff that they're allergic to, but we need to drill down into that, and we need to start separating what's going to be a life-threatening reaction where they go into anaphylactic shock, and what's something that they it just has sort of a weird effect on them. And we'll get into more of that later. We want to learn relevant facts about the patient's past medical history so that we can determine what's going on. So we're going to use this thing called sample history. And the sample history gives you a framework to ask questions about the patient. Some general tips here. We want to ask the patient one question at a time. And then we want to give the patient time to answer that question, right? We want to listen carefully. We want to use good eye contact. We want to use our active listening skills. Repeat the information back to the patient to make sure you got the right answers. And be generally inquisitive and ask follow-up questions. So if we look at sample history, in your textbook, table 9-1 gives you the basics of sample, right? But we're going to drill down into it here a little bit deeper. So S stands for signs and symptoms. A stands for allergies. M stands for medications. P is past pertinent history. L is last oral intake, and E is the events leading up to the condition, right? And your textbook will give you a little bit of data on each of these, but let's dig into this a little bit more. So what is the difference between a sign and a symptom? So signs you can measure. Symptoms have to be described to you. So one is objective and one is subjective. One you can see and one you can't. So when you so can anyone give me an example of a sign?
maybe like a laceration or something.
Right. So yeah, you can see that they have a laceration. You can see that they have a bone sticking out of their skin. Right. You can see a rash. You can measure a heart rate. You can measure a respiratory rate. These are all signs that we can collect. Right. In fact, they're called vital signs. A twisted ankle is not a sign unless you have bruising and swelling with it, right? A twisted ankle is, in a lot of cases, they'll describe pain, right? They'll describe tenderness, the inability to bear weight, right? Those things could be symptoms. But swelling, bruising, bleeding, those can be considered signs. So, excellent. We'll move on to allergies. So when you ask if someone's allergic to something, right? So you've just asked me what I'm allergic to. And I say, I'm allergic to milk. I'm allergic to bees. I'm allergic to Benadryl. And I'm allergic to gluten. What is the very next question you're going to ask me for each of those?
What are your symptoms when you have those things?
Yes, absolutely. What happens when you take bees? What happens when you drink milk? What happens when you eat gluten? Right? You want to ask for each of those. How bad is the reaction? Right? And Daniel said, "Is it life-threatening?" Yeah, that's basically what you're looking for, right? So, so if I tell you I'm allergic to milk, what are you going to ask me? Anybody?
Did you have any milk?
Well, did you have any? Yes, that would be an important one. And if I say no, what are you going to ask me when I say I'm allergic to milk?
What happens when you have milk?
What happens? That's a great question. I poop a lot. Is that an allergy?
No.
No, it's a sensitivity, right? I'm sensitive to milk. I'm lactose intolerant, right? In that case, if that were true. But it is not an allergy. But this is the type of stuff that you would ask under allergies. So I tell you that I'm allergic to bees. What are you going to ask me?
What's the severity of the reaction? I guess when you get stung.
Yeah. What happens when you get stung? Well, I swell up like a balloon, my airway shuts, and then I die. Is that an allergy?
Yeah.
Absolutely. And my next question is, do you have an EpiPen, right? Or have you been exposed to bees recently? If I tell you that I'm allergic to Benadryl, what are you going to ask me?
You've taken it.
Right, that's a good question, right? What else would you ask? We're on a roll here.
What happens when you take it?
What happens when you take Benadryl? Does everyone know what Benadryl is? Have you ever seen that? It's an over-the-counter medicine. And if I tell you, when I take Benadryl, I get sleepy. Is that an allergy?
That's a
No, that's a side
reaction.
effect.
That's literally what the medicine is for, right? When you go and buy over-the-counter sleep aids, a lot of them have Benadryl in them as the thing that makes you go to sleep. So if I take Benadryl because I have like itchy eyeballs or something like that, then yes, it's a side effect of the medication, but it's not an allergy. Like we fully expect that to happen, right? And then finally, I'm allergic to gluten. What are you going to ask?
What happens
happens when you
when
take
you
it?
eat gluten?
That's an excellent question. I'm so glad you asked. I get stomach cramps, right? And so is that an allergy?
No.
No, but
No.
it could be a sign of something else, right? I could have celiac disease or something like that, right? So it is an indicator of another underlying condition. So those are all sort of, this is an example of we have an A in sample and it means allergies, but really when we dig into this, we can get a lot of additional information about the patient if we just remain sort of clinically curious. So make sure that you ask those follow-up questions. What happens when you are exposed to that specific allergen? And you can get a lot of information. So next up we have medications. So medications, there's a lot of different things. There's a lot of different things you can consume medicinally, right? And so when we think medications, we think stuff that's prescribed, right? You go to a doctor, they tell you have to take a pill, and you get that pill from a pharmacist and you take it, right? That's what we're looking for a lot of the times, and that's what they'll tell you a lot of times. When you're asking about medications, is it important to know what every single medication does?
Yes.
Okay. I mean, I won't disagree with you, but I will say that you will invest a lot of time and energy into things that are not necessarily important right now if you focus on what every single pill on their list of pills is for, right? You should have a general idea of why they take their pills, right? So if I tell you that I take lisinopril, amlodipine, and Norvasc, do you know exactly what all of those things do? No, right? But what's the next question you're going to ask me?
What do you take them for?
Right.
Exactly. The patient is, in many cases, your best walking reference document for what that medication is for. And so if I tell you I take two medicines for the blood pressures and one for the cholesterols, you have a general idea of what medications I take and why. And that's all you need to know to get a general picture of what medications someone's taking and why they're taking them, right? And then you're going to follow up with what question?
How often do you take them?
Well, I normally take them twice a day, but I ran out and I don't have enough money to go to the pharmacy to pay my copay, so I guess 0 times a day. So what's the next question you're going to ask?
What typically happens when you don't take your medication?
I would probably ask, when's the last time you took your medication? Like, how long has it been since you have taken this medication? And that sort of gives you an idea of what happens when you don't take those meds, right? Because here we are. We've arrived on scene, right? They're having some kind of medical emergency. We can see what happens when they don't take their medicine. We just want to know how long it's been since they've taken their medicine so we can get a general idea of how bad it is. And in speaking about medicines, the other thing that I want to talk about is that there's a lot of different types of medicines. So we're talking about prescribed medicines, but you can also go to a pharmacy and buy a lot of medications without a doctor's prescription, without a pharmacy approving it, right? These medicines are called over-the-counter medicines. These are going to be your Benadryl for sleep or for allergies. These are going to be your ibuprofens and your acetaminophen for over-the-counter pain relief. And there are a lot of different over-the-counter medications that are evaluated by the FDA to treat some kind of condition. And some of these medicines can be very dangerous. One of the most dangerous over-the-counter medicines that you can buy in the United States is Tylenol, acetaminophen. In fact, the FDA said that if a company came to them today with Tylenol and trying to get it approved for over-the-counter selling, they wouldn't approve it because it is so dangerous. You can overdose on Tylenol very, very easily, and it can have lethal effects. So just because it's sold over-the-counter doesn't mean it's safe. The dose makes the poison, as it goes. We also have supplements. So supplements are things that are not evaluated to treat any medical condition, but you can still buy in stores. These are like vitamins or workout supplements, your protein powders and pre-workout stuff. And you can also overdose on these. But a lot of times these supplements are very benign, and most supplements that you purchase, especially vitamins, you're effectively just making really expensive pee, because your body will take what it needs and will just urinate out the rest. So a lot of supplements that people take will not do much. But it's important to get an idea of what they're taking, how often, and for what reason. And then finally, we have recreational stuff, right? So there's a lot of things that people will take recreationally. Drugs such as ethanol, also known as drinking alcohol, right? A recreational drug such as caffeine. There's a lot of caffeine abuse in this nation. We are just a wired population. Cannabis is legal in a lot of different states. Tobacco is a recreational drug, right? And so we want to get a sense of all of the substances they consume, because it all leads to a better clinical picture of what's going on with the patient. As Daniel takes a sip of Mountain Dew. Yes. And really the toxic substance present in Mountain Dew is sugar. And so we're going to talk about diabetes in a different section of the course. All right, so next we have past pertinent medical history. And there's really three categories of past pertinent medical history. There's the chronic stuff that's been going on for years. There's the acute stuff, and this is usually why they called 911. And then there's stuff that's what we call acute on chronic. So this is a condition that they've had for years, but suddenly it got worse. And so like a chronic heart condition or a chronic breathing condition, right? If they have asthma, but their great aunt from Florida came up for Thanksgiving and she chain smokes, and all of a sudden Sonny's having an asthma attack. Well, that's a chronic condition that he had that was acutely exacerbated by toxins in the environment, right? And so we want to get an idea of not just what's been going on in their medical history that may be related to this, but is it a chronic problem, an acute problem, or an exacerbation of an existing condition? Last, oral intake. Now, I think this is a dumb question, and I'll tell you why I think it's a dumb question. Because DUMB is also an acronym. That's right. So DUMB stands for what have you drank recently? Have you peed recently? What have you eaten recently? Or what have your meals been like? And is that normal for you? And then what have your bowel movements been like? And is that normal for you? Now, are you going to ask every single patient about their last bowel movement? I'm asking honestly, are you going to ask people about their poops? No. No, I'm not going to ask the person who's complaining of a respiratory complaint about their pooping habits, right? But who am I going to ask about their last bowel movement?
Abdominal pain.
Yeah, absolutely. Because that's the organ system that may be affected, right? If they're having abdominal pain and cramping, I want to know if they've had normal bowel movements. If they're not urinating and they're not passing stool, are they dehydrated? You know, there's all sorts of stuff that we can get out of someone's eating and drinking habits. Now, so Reagan asked, for the supplements, are there any that shouldn't be mixed with medicines that might be given? Vitamin C. All right, so that's a good question. So, and this is really sort of a higher level medical question, but yes, there can be drug interactions. And let's go back to medications. So, where we see people getting into trouble, especially with the elderly, if they go to their doctor or they go to a new doctor and they get a new medicine prescribed or they get the dosage changed on one of their medicines, they will sometimes come home, and if the change is sudden, they didn't taper on or off a medicine, they can have untoward effects from dosage changes or an additional medicine coming in and causing side effects with all of their other medicines. And this was a huge problem before hospitals started communicating with each other using electronic medical records, where two different doctors wouldn't see what they were prescribing the patient and wouldn't know that two drugs were going to interact. Now, in terms of, for example, your diet interacting with medicine, I'll give you a quick example and then I'll move on because this is sort of outside the scope of what you're expected to know. But someone who was on blood thinners, who consumes lots of vitamin K, and this is the sort of vitamin that you find in dark leafy green plants like spinach and stuff like that. Vitamin K makes your clotting system in your body more powerful. And so if you're on a medicine that's supposed to reduce clotting and you eat a lot of dark green leafy vegetables, or you decide that, you know what, today's the day, I'm gonna start cleaning up, I'm gonna replace every Twinkie that I used to eat with a pound of spinach, right? I'm gonna clean my act up. Well, what you've done is you've increased the amount of vitamin K that you're consuming, and you're likely to form clots that the medicine wasn't calibrated for. And so that's one example. There's lots of examples. Your vitamin C example, I think you're talking about grapefruit, not vitamin C, because grapefruit has a certain enzyme that competes in the liver for certain pathways that metabolize drugs. And so there's a bunch of medications that you're not supposed to drink grapefruit juice with. And there's just so many examples of this. And there's a whole semester of pharmacology that we could talk about that we just don't have time for, unfortunately. But yes, you are correct. Lots of things that we consume interact with other things that we consume. All right, so finally, we've done SAMPL, and the last thing on the list is events leading up to what's going on today, right? And so this is establishing a timeline. What was going on? What did you do? What did you feel like, right? And the reason why we're asking about their feelings is things like seizures will have an aura that comes on. If they're having a diabetic crisis, they may say that they felt drunk. Or bystanders will say that they appeared drunk. If they had a syncopal episode, like they stood up too fast and they got lightheaded, they may describe themselves as feeling dizzy. And you want to ask these questions. How did you feel right before this incident? What were you doing right before this happened? And this will give you a lot of clues as to what is causing the event. So that is sample history. You are going to use this a lot. This is very, very high yield. You need to know sample, you need to know what every letter of sample stands for, and you need to know why you're asking those questions. So, I ask you, do you have any questions about sample history?
I'll ask one, I guess. And I think it would come up in past pertinent history, but like past surgeries or anything, especially if it's, but I mean, would that go more under sort of chronic because it's something that they've been dealing with?
Maybe. Yeah, absolutely. So you absolutely want to ask about surgeries. So I'll give you an example. So you get called to a mid-30s female who just had a baby via cesarean section, and now she's complaining of severe shortness of breath. Now, we're going to get into some of these things, right? But what is happening most likely in that case is her surgical experience has created clots that traveled up into her lungs and are now giving her something called a pulmonary embolism. And so in that case, that is an acute condition. The surgery that she had, a couple days ago is now causing another acute problem. So that's acute on acute. But the surgery is directly responsible for that. A chronic condition, surgery, if you had a surgery and you recovered from your surgery and you didn't have complications immediately after your surgery, generally speaking, you're not going to have chronic conditions after that. Maybe if they mess the surgery up and you have chronic pain or something like that, that would be sort of a chronic surgical experience. But a lot of complications from surgery are going to be acute. Does that answer your question?
Yep, absolutely.
Answering the question or successfully avoiding it. All right. So we've been going for another hour here. We're just about halfway through. So what I want to do is cut you guys out for another 10 minutes. Come on back at 9:25, and then we'll power through the rest of secondary assessment and reassessment. All right. So take 10, and I'll meet you back here at 9:25. And we can now get into secondary assessment. So the secondary assessment is done to assess any non-life-threatening conditions, right? So remember that primary assessment is to identify and treat life-threatening conditions that are going to kill your patient immediately, and it's done very, very quickly. Usually you can complete your primary assessment in as little time as you can hold your breath. The secondary assessment is your inventory of non-life-threatening conditions. So you're going to assess in a slower, more methodical and systematic manner from head to toe if needed. In addition to this, vital signs are taken as part of your secondary assessment. So in many testing scenarios, if you start taking vital signs before you finish your primary assessment, you'll actually fail the station immediately. Because if you're stopping to take the time to record a set of vital signs when you should be fixing things that are going to kill your patient immediately, your patient will be dead by the time you get your vital signs, or your vital signs will all be zeros. And either way, it's bad. So don't do that. Secondary assessment is when you're going to take your vital signs. So the physical examination helps you locate and begin initial management of signs and symptoms of illness or injury. And remember, signs and symptoms, a sign is something that the patient or you can see or feel for yourself, and a symptom is something that the patient has to tell you about their condition. So you need to be able to assess and select signs and report them systematically while you transfer patient care. So in your book, you have tables 9-2 and 9-3. And I consider these very low yield acronyms. This is basically giving you a framework to figure out what is not correct about a given body. I don't like these. I don't use them. I don't generally teach them because it's very easy to say you're looking for DCAP BTLS and not know what every letter stands for. And it's better for you to do a thorough assessment, to visualize the underlying organ system and know that, okay, if the abdomen is not soft and non-tender, that there is something going on here, and I can describe that something. The abdomen is hard, or the abdomen is swollen, right? And I don't need to use terms like, I don't know, there it is, tender, swollen, right? I can describe these things. I can say that, he appears to have a laceration on his arm, right? I don't have to say he's positive for DCAP BTLS. But some people find it beneficial to have a mnemonic like this to give them a list of things to look for. But ultimately, what you're looking for is anything that is not normal for the patient. And how do we know what normal is? We assess a lot of patients who are not sick. And that's what we're going to do on our Saturday skill sessions. We're going to be assessing each other a lot. And so a secondary assessment of the entire body is performed usually on someone who is unconscious, is traumatized, or is for some reason a bad historian, someone who cannot be relied upon to give you an accurate medical history. So whether that's altered mental status, maybe they're intoxicated with something, but in any case, you've determined that you need to systematically assess their entire body. So this is going to be a thorough, hands-on, full-body assessment in a logical, head-to-toe, systematic manner. And then once you collect this information, you're going to use a clear, concise format to communicate these findings to other medical personnel. And I'm going to give you a format that works very well. The full body assessment can be done whether the patient is conscious or unconscious. You want to assume that all unconscious injured patients have spinal injuries and treat them accordingly. And then we're going to, in a systematic manner, assess the head, the eyes, the nose, the mouth. We're going to move down to the neck. We're going to assess the bones of the face. Well, we're going to assess the face and then move to the neck. Once we've looked at the neck, we're going to move to the chest. Once we've assessed the chest, we move down to the abdomen. We check the pelvis for stability. And then we assess the extremities, starting with the legs. We'll move up to the arms. And then once we have assessed the entire front of the patient, we're going to log roll them, and we're going to assess the back. And this is where we put something underneath them in order to do our lifting and moving. And so this is the sequence of your secondary assessment. It follows that same sequence every single time. So some people will assess the back before they check the extremities. Some people will check more things like the stability of the shoulder girdle or whatever. Again, I don't care what system you use as long as you have a system and you use the same system every single time. The moment you start jumping around is the moment you start missing things. And so I'm going to give you this particular system, this particular set of things to check. You're going to get really good at it. And if you want to add things to it later or move the sequence around based on your personal preference, then you can do that. But just make sure that you have a system and you use it every time. In some cases, the patient is alert, is oriented to person, place, time, and event. They can speak with you. They can tell you, gosh, my elbow really hurts after I fell down. So if the patient gives you a chief complaint and seems like they're a reliable historian, right, do you need to do a full head-to-toe examination for an elbow injury or for a knee injury? Morgan says yes. She's going to go head-to-toe on every single patient. I appreciate your dedication to detail. But no. Some patients may find it a little weird that they stub their toe and you're checking their eyes, but personally, I'm a...
So I was thinking more so like if you had somebody, let's say, who fell down, right, to their elbow,
Mm-hmm.
but let's say they're elderly or something, wouldn't there be concern? So, okay,
yes.
So I guess I should, so depending on the situation, but just because someone, bumped their elbow when they fell, okay, but is there a reason they fell? That could be another issue that's not readily seen. So that's really where my thought was on that.
I love your thinking. I think you have a bright career in EMS because that is some next level thinking. Absolutely. So what you described was someone who fell down, right? And now you have additional concerns based on what? What do we call that? We discussed it earlier tonight. I'll give you the letters. It's MOI.
Mechanism.
Oh, mechanism of incident.
A mechanism of injury, exactly. You're taking into account their mechanism of injury. And even though Nana Noodle is now sitting up in her lazy boy and she says, I feel fine, my elbow just hurts, I don't need to go anywhere, be seen by anyone. What you're concerned about is maybe she doesn't hurt right now, but did she hit her head? Does she have a potential brain bleed? Her bones are frail and bird-like, and they break like sticks of chalk. So does she have a fractured pelvis that she's not telling you about? Absolutely. And you do want to be thorough and systematic. And also, I will tell you, and I tell this to higher level students as well. Whatever they're complaining about, I usually want to check the organ system, in air quotes here, above and below. So I usually don't let anyone escape my ambulance without having conducted several assessments on them on several different organ systems. And so, if they're complaining of, elbow pain, I'm definitely going to check their lung sounds. Maybe they hit their ribs or something. I'm definitely going to, if they hit their head, I'm definitely going to check their eyes. I'm definitely going to, do all sorts of additional exams. And this does a few things. First, it's just being thorough, right? You're being a medical professional. You're doing your due diligence in assessing the patient, properly. You've come all the way out there to go get them. You might as well do a good, thorough assessment. And second, even if everything is normal with them, even if you don't find anything wrong with them, you've done a successful repetition of a useful skill, and you've determined, once again, you've built out your library in your mind of what normal looks like, so that when something that's not normal shows up, you know that ain't normal, right? And we have a fancy term for this in medicine. It's called your gestalt, right? This is the collection of all your medical experiences that allow you to make good decisions, right? And so I highly encourage that you do thorough assessments. But I think the point of this slide is that you don't need to do a systematic head-to-toe examination of someone with an isolated complaint who you believe is a good historian. So there's a line there, right? And you have to determine what you're going to assess and what you're going to leave out. And this is for alert, oriented, non-traumatically injured patients. So let's talk about vital signs. So the vital signs that we want you to check are going to be their respiratory rate. That's the number of times per minute that they're breathing. Their heart rate, also known as pulse. This is the number of times their heart beats in a minute. And their blood pressure. Those are the big three vital signs that you're expected to be really good at taking. Now, there are other vital signs that you'll probably take. You'll probably take someone's temperature. You'll probably put a pulse oximeter probe on someone's finger. And we're going to talk about all that stuff too. But what I expect you to be really physically good at, if you were on scene with me and I asked you to take a set of vitals, I would absolutely want you to, down cold, be able to give me a respiratory rate, a heart rate, and a blood pressure. And those are the big three that we're going to focus on. So we'll kick it off with respiratory rate. So respiratory rate, again, the number of times someone breathes in a minute. Not only are we looking at breathing rate and quality, just is it too fast or too slow, is it too deep or too shallow, but now we're going to take the time to count every time they breathe in fully and they breathe out fully. That is one respiration when you breathe in and you breathe out. The normal number for an adult, and it's different for kids, we'll get into that, but the normal number for an adult is 12 to 20. 12 to 20. You are going to be responsible for that information. You are going to be asked questions that give you a respiratory rate of 8, and you're going to have to identify that as being too slow, right? 12 to 20. If I give you a respiratory rate of 24, you need to say that's too fast. 12 to 20. So how do we measure respiratory rate? So again, it's one cycle of inhaling, which is breathing in, and exhaling, which is breathing out. That counts as one breath. And we want to count the patient's breath for 1 minute to determine the respiratory rate. Now, a lot of people don't want to wait around for 1 minute. That's a long time, especially when you're assessing someone in the back of an ambulance. And so here's a trick for you. And this is a certified, official rubber stamp trick here. You count the respirations for 30 seconds, and then you multiply by 2. Now, I'm not a fan of public math, but somehow I've managed to make it 16 years into my career, and I've been able to multiply by 2 on multiple occasions, and it's worked out for me pretty well. So count for 30 seconds, multiply by 2. Now, could you count for 15 seconds and multiply by 4? Or count for 6 seconds and multiply by 10? I mean, you could, but the less time you spend counting the breath, the more inaccurate your number is going to be. And so counting for 30 seconds and multiplying by 2, that's the sweet spot for accuracy, right? And pro tip, you should get an even number when you do that. If you get an odd number, you did it wrong. That's a math joke. All right. So that is how we assess respiration. Now, the next thing we want to check is heart rate. Now, heart rate is also called pulse, but there's a difference between a pulse and a heart rate. A pulse is the feeling you get under your fingertips when you press an artery against a bone. It's the physical sensation of your heart beating and pushing blood. The number of times that happens in a minute is your heart rate. So we can get some information from the pulse. So for example, if you were to put your fingers on your radial pulse and it feels like it's about to beat out of your wrist, right? We call that a bounding pulse. Your heart is beating very forcefully, lots of contractile strength, right? And that could be a good thing, or it could be an indicator that you have really high blood pressure. Likewise, if you search for a pulse and it feels like a bit of thread is just being pulled under your fingertips, we call that a thready pulse. And that's an indicator that you have a failing blood pressure. That's an indicator that you may be going into shock, right? So you can get some information from the pulse itself, but what we really want to know is their heart rate. So what you're going to do is you're going to find a pulse and you're going to look at your watch. And I highly recommend a watch that can count seconds. If you have an analog watch, I don't know anyone who has an analog watch, so if you have a digital watch with an analog mode, that watching the second hand works out really well for me. You want to count the number of pulses you feel in 30 seconds and then multiply by 2. And that number is their heart rate. And we'll get plenty of practice doing this. A normal heart rate for a normal adult human is 60 to 100 beats per minute. And this is a normal resting heart rate. So Morgan asks in the chat, so should I start wearing a watch? And my answer is only when you're on duty.
I'm volunteer, which means every day. I stopped wearing one when I separated from the military. So I haven't worn one in an awful long time, but
is that kind of like when men get out of the military, they always grow a beard?
I guess, yeah, it was, hey, I don't have to be any one place 15 minutes early, so I'm done with the watch, but I can get one.
Well, now you are entering back into a profession where wearing a watch is a necessity. You have to be able there's no way you're going to be able to get these numbers if you don't have some kind of timekeeping device, right? And if you can't get these numbers, you can't work in medicine, right? Now, if you're exceptionally lazy, like some of the, no one at EMS is exceptionally lazy. But imagine, if you will, someone who had one of those big fancy monitors in their truck and they just put the cuff on the arm and put the sleeve on the finger and press the button and get all the numbers. You could do that. But as EMRs, we'll find ourselves in situations where we don't have access to that high technology. And so we're going to have to take a manual blood pressure. We're going to have to take a manual pulse. And so you're going to need to have a manual timekeeping device. So again, the normal heart rate in a resting adult is between 60 and 100 beats per minute. Now, if someone has a heart rate of 120 beats per minute, is that always bad?
No.
When would a heart rate of 120 beats per minute be good?
For someone who might be overweight.
Catherine says a brisk walk. That's right. That's the cardio zone. Come on. You got to do your cardio. Right. So your heart rate will respond to your body's oxygen demand, right? It responds to a bunch of things. You know, you can scare someone and get their heart rate up. But generally speaking, it responds to metabolic demands in the body. And so if you're running on a treadmill, I'd expect to see your heart rate up around 150, 160, right? Depending on your age. And likewise, if your heart rate is less than 60, is that always a bad thing? So Danielle put it in the chat, right? So I think she's I think she's onto something. Do you know? So she says bradycardia. So that is the technical term for a slow heartbeat. Although we don't need to know that for this class. But yes, so high-end athletes, and the example I like to use is Lance Armstrong because pretty much everyone still knows who he is. but he had a resting heart rate in the low 50s and upper 40s, which if I saw anyone normally with a heart rate of 40, I'd be getting out like electricity devices and giving this person medicine. But that was just normal for him because his body is so efficient at processing the oxygen that he takes in, and his heart is so strong and capable that that's where he's at. And so how do we tell if someone's heart rate is good or bad? Can we tell by just looking at the number?
I'm assuming you'd probably have to take in other data.
Yes, Andrew, absolutely. No one number that we pull out of a patient is going to give us a complete clinical picture of what's going on with them, right? Not their breathing rate, not their heart rate, not even their blood pressure in isolation is going to give us a complete picture of what's going on with the patient, right? So we need to do what's called clinical correlation. All right, they have a respiratory rate of 28 and they have a heart rate of 160. I'm going to clinically correlate this with the person just ran away from a bear. I think that they're clinically fine. Maybe they need to change their pants, but there's no medical intervention necessary here. But likewise, if I come across someone laying in their bed, I'm called to someone's home as a sick patient, and they're laying in bed and they look pale, and their heart rate is 40, and their respiratory rate is 8, I have a very different clinical picture of that person. I'm like, this patient is in some kind of shock, and I need to figure out why and get them to the hospital. And so we have to take in the entirety of the patient in order to understand what we're looking at. Okay, so the next thing we want to talk about is capillary refill. So you have... So Daniel's asking the shortcut for counting breaths. Was it count for 30 seconds and multiply by 2? Yes, absolutely, because we want to get the breaths per minute or beats per minute of the heart. And so we can shortcut that by counting for 30 seconds and multiplying it by 2, which gives us 60 seconds, which is 1 minute. So capillary refill, we talked about blood vessels in anatomy and physiology on Wednesday, and we know that we have arteries carrying blood away from the heart, and we have veins returning blood to the heart. But in between the arteries and veins, there's a space where the oxygen is diffused into the tissues and the carbon dioxide is picked up by the blood, and that's where gas exchange takes place. And this is referred to as the capillary bed. And every cell in your body is within about 5 cells away from a capillary. The capillary bed is, by surface area, the largest part of your body, just because it needs to transport oxygen to everything. And so it actually turns out to be a really effective way to determine someone's perfusion status, which is the blood getting to where it needs to go? And so what we can do to measure capillary refill is we can take any part of their body that has the rosy redness of blood, right? So a fingernail bed, the tip of someone's nose, an earlobe, any bit of skin where you can see that it is pink with blood, and you squeeze it. Give it a good squeeze for a second or two, and then release. And you should see that it starts off pale because you squished out all the blood, and then the rosiness returns back to it, right? So I see a couple people looking down at their nails. This is good. Go ahead, give your nail bed a squeeze, release it, and then watch the whiteness almost instantly go away. Now what we're looking for here is we want that rosiness to return in less than 2 seconds. If you have a good strong heartbeat and you're pushing the blood around where it needs to go, then that blood should pop back into the capillary bed within about 2 seconds. Now, if you squeeze your finger and it takes more than 2 seconds for that blood to flood back in, then you have diminished perfusion in that area, right? And this is concerning. Again, no one sign in isolation is going to give you a complete picture. So if you squeeze your finger and it takes you 4 seconds to get the blood back, you may not be dying yet, but you want to put it in perspective with everything else that's going on, right? Alrighty. So let's talk about blood pressure. This is super important. So blood pressure is divided into two numbers, what we call the systolic blood pressure and the diastolic blood pressure. Systolic, the high number, this is the pressure that is exerted on the arteries when your heart squeezes. So your heart forcefully squeezes, it squeezes all the blood out, and that creates a pressure wave through your arteries that we feel as a pulse. Now the heart relaxes after that, and when it relaxes, it fills back up with blood, and that low pressure state, the low number, the bottom number, is your diastolic pressure. So we are really concerned about both of these numbers, but if we had to choose just one, the top number is the most important. And so we're going to teach you how to take a blood pressure where you only get the top number, and we're going to teach you how to take a blood pressure where you get both numbers. Now, just to go back and hit that a little bit harder. So the normal values for a blood pressure, we want to be somewhere in the range of 120 systolic over 80 diastolic. 120 over 80, you'll hear, is like the perfect blood pressure. Now, that's just the average. There are some people who are slightly higher than that. There are some people who are slightly lower than that. But significantly higher than that, so for example, if that top number is over 140, we would consider that person to have high blood pressure. And if that number is lower than 90, we would consider that person to be hypotensive or concerningly low blood pressure, right? And so again, this number doesn't tell you everything, but there are certain critical points where it's too high and too low. We talked about skin color, temperature, and condition. So skin color, skin temperature, is it warm or cool? And then condition refers to the moisture. So is it sweaty? Is it dry? Is it cracked? We know that normal body temperature. So Dustin asks, that's for adults. What about children? We're going to cover all child vital signs in the child section because there's a lot of them. All right, so we're going to focus on adults for now, and then we're going to, once you have the concrete knowledge, we're going to throw in all the curveballs later. So skin color, temperature, and condition. Normal body temperature is 37 degrees Celsius or 98.6 degrees in freedom height. Medicine is increasingly using the metric system because it's divisible by 10 and relatively easy to understand. But you'll hear both, right, when it comes to temperature, both Fahrenheit and Celsius. But 37 degrees Celsius, 98.6 degrees Fahrenheit. Normal skin, so the skin of a healthy, well-perfused, rested person is usually described as warm, pink, and dry. Now keep in mind, not everyone is pink, but warm, dry, and of appropriate tone works as well. Now, there are other things that we will learn to assess when we do our secondary assessment. Pupil size and reactivity is one of the things that we'll look at, and we'll tell you certain things. And so we'll get into this a little bit more when we talk about strokes, seizures, and toxic overdose. And then level of responsiveness. We talked about this before, and we use the AVPU scale. Now, there are other scales used in EMS to determine level of responsiveness and general mental status, but we're not going to talk about the Glasgow coma scale or anything like that. That's a lot to remember, and this is a very short, very fast course. So when we talk about level of responsiveness, again, we're using that AVPU scale. So once we get through our secondary assessment, and remember, we're checking the head, the eyes, nose, mouth, ears. We're moving down to the neck. We're moving to the chest, the abdomen, the pelvis. We're going to check all the extremities, the lower extremities, the upper extremities, and then we're going to roll them over and check the back and then roll them back over on a lifting and moving device. Once we've done all of that reassessment, then we're going to move on to, once we've done all that secondary assessment, we're going to move on to a reassessment. And so reassessment generally occurs either while you're waiting for the ambulance to arrive or en route to the facility that you're transporting to. And so what does this consist of? Well, basically, you're just going to do everything all over again. You're going to reassess the patient's level of responsiveness because you're going to be talking to your patient the entire time. You're going to reassess the ABCs, always thinking to yourself, well, this person's talking, their airway must be open, or, well, this person hasn't said anything in a while, are they still breathing? And I have done this on long transports. I'm like, are they still breathing? Hey, Mr. Jones, you want to wake up a little bit for me? It happens. And continue to maintain that open airway, monitor breathing, and then reassess their vital signs. So not just the quantitative vital signs like heart rate, respiratory rate, and blood pressure, but also these subjective vital signs like skin color, temperature, and condition, and their general appearance. We also want to reassess their chief complaint. Hey, Mr. Jones, I know you said you had 8 out of 10 pain before. How's your pain now? 9 out of 10? Well, that's not good. But you're reassessed, which is important. And then you want to recheck the effectiveness of your treatment. So, for example, if you found that they had a laceration and you applied a bandage, is that bandage now soaked with blood? That is bad. We would want to address that because our initial intervention wasn't working. Likewise, if we did an intervention, like we wrapped up an injury, and the bandage is clean, dry, and intact, that's great. You did a great job, and the intervention is holding. Either way, you've reassessed it, which is important. Now, the frequency that you reassess someone is based on how critical their condition is. So a stable patient, you're only going to reassess them every 15 minutes or so. But if the patient is unstable, you may have to retake a set of vital signs, do an airway breathing circulation check every 5 minutes to make sure that they are not trending downward all of a sudden. Because remember, patients don't get suddenly ill. Providers suddenly notice. All right? And if you're not checking, you're not noticing that they're suddenly getting worse. And then finally, part of your reassessment is preparing to hand this patient off to other medical providers. So I'm going to give you a format for communication when we discuss communication. It's called IMIST, which stands for Identification, Mechanism, Injuries, Signs, and Treatment. And if you use IMIST every single time, not only are you going to give a great report, and you're not going to be on the radio forever giving this person's entire life history while the nurse on the other end nods off, but you're going to have to consolidate all the information that you've picked up and sort of logically form what's going on with this patient in your mind. So it's a really great cognitive tool as well. All right, so a word about medical and trauma patients. So we generally, like Dave said on Wednesday, there's 2 buckets of patients. There's the trauma patients and the medical patients. Sometimes they're both, but generally speaking, if they're traumatized, they're a trauma patient. If they're not traumatized, they're a medical patient. And so the patient assessment sequence used has a little bit of a change between trauma and medical. And basically, if they're a trauma patient, we're not going to stop and ask questions first. We are going to go straight from our primary assessment into our head-to-toe physical assessment, because what's going to kill them? The things that are the information that we're going to get by asking them questions, or the physical findings that we're going to find because they're traumatized, right? If they didn't have some sort of life-threatening condition, but they still have big lacerations, or they have a big hole in their back, and because they were laying flat on the pavement, we didn't notice it and it wasn't bleeding. But as soon as we roll them over, we see that they have a big hole in them, right? I've learned the hard way on that one. We want to jump straight into our physical assessment. And then once we know we've cataloged all their injuries and treated the important ones, then we can start to get this medical history. And so that is emphasized. We're going to emphasize that more tomorrow when we meet up. All right, so summary. A complete patient assessment consists of 5 steps: scene size up, primary assessment, medical history, secondary assessment, and then finally reassessment. Scene size up is a continuous process. It's a general overview of the incident and its surroundings. Based on what you find, you make decisions about the safety of the scene, the type of the injury, or type of incident, mechanism of injury, and whether or not you need additional resources. Your primary assessment is to determine and correct any life-threatening conditions. These steps are very quick and need to be conducted before anything else goes on. And then you're going to obtain a medical history to gain a systematic account of the patient's past medical conditions, illnesses, injuries, allergies, and all that stuff. The sample history framework allows you a systematic way to collect all this information. The secondary assessment consists of an entire body survey, head to toe, for non-life-threatening conditions. It's only done after completing the primary survey and stabilizing the life-threatening conditions. And so this secondary assessment helps you locate and begin management of other types of illness or injury, as well as taking a set of quantitative vital signs. And then the reassessment allows you to carefully watch all patients for changes in their status. Remember that patients don't become suddenly ill, providers suddenly notice. And so based on the criticality of the patient, we're either going to assess them every 15 minutes or every 5 minutes. All right, so a question in the chat, Leo asked, should we bring our books tomorrow? I would bring your book. In fact, after I graduated paramedic school, I kept my textbook with me for the first 5 years of my career, and I would look up every call afterwards to make sure that I learned what I needed to know. So I'm a big fan of having a reference document with you. That said, tomorrow will mostly be focused on physical skills, and we'll teach you everything that you need to know. So do you need it? No. Should you have it? I'd recommend it. All right, so it is now 10 o'clock. I have review questions and I have a case study, but I am not going to go through them. If you want to stay afterwards and run it, I'll wait 5 or 10 minutes for people to run for the hills, and anyone remaining afterwards will go over some review questions. Otherwise, does anyone have any questions about what we covered tonight or questions about skills tomorrow? It says a bunch of people are typing in the chat, but there's no messages showing up. Andrew says C. Does that mean yes? Are you saying C in Spanish that you have a question?
I just wanted to answer the question.
Oh, okay.
Sorry.
Any questions about skills tomorrow? Everyone know where they're going? All right, so Daniel Ellingwood says, where is the Walpole station? I think that's a pretty good question. So, let me... Look, it even has a picture of the room that we're going to be in. So, 278 Main Street in Walpole, and it is a big building. It has signs out front. And then when you get there, you park in the back. So if we switch over to the satellite view here and do a little CAA spook type stuff, you'll come up on Main Street and then you just come into the back and park in any of these spots over here. And then the door is right here. And then the classroom that you see in the picture is upstairs. So go right in the front door, make sure you're wearing a mask, up the stairs, and into the big room. Bethlehem crew, are you familiar where the North Country training facility is? Cool. All right. Well, I'm going to stick around for additional questions. Anyone with concerns, comments, if anyone wants to do the review questions in the case study, I'll let them, I'll go through that with them. Otherwise, you are all released, and I will meet a third of you tomorrow in Bethlehem. Have a good night, folks. All right, so we got people leaving. So anyone remaining who wants to, which of the following steps might be performed during the scene size-up? Assessing vital signs using appropriate monitoring devices, forming a general impression of the patient, notifying dispatch to send fire personnel, or performing a full body scan. All right, indeed, it is C, but why is it C?
Because it's the only one to do with the scene.
Exactly. So it's important not to confuse scene size up with the initial steps of the primary survey, which are going to be form a general impression, determine level of consciousness, and assess for life threats. So absolutely. So the goal of the primary assessment is to quickly diagnose the patient's condition, determine the need to perform a full body assessment, determine the number of patients, or identify and treat life threats.
D.
That's right, Delta D. So diagnosing is something that we do before we start treatment. So in order to form a diagnosis, we want to make it through our secondary assessment. We want to ask all the medical history questions and get a more complete picture of what's going on with the patient before we say something like, oh, okay, this person is having a diabetic crisis and they need, oral glucose or something along those lines. But it is something that we will eventually do because in order to do treatment, you have to have an idea of what's going on, right? So we're not going to do that in a primary assessment. All right, moving on. After performing a primary assessment and treating any immediate life threats, you should next determine the priority of patient care and transport, reassess the patient, recheck your interventions, or promptly transport the patient to the closest hospital. I think there's two answers that may be attractive here, but there's only one correct answer. I like it. We get a little bit of controversy. All right, so we're split between A and C. So after performing your primary assessment, what is the primary assessment?
A very quick assessment to determine if it's life-threatening or not.
Right, so your primary assessment is your ABCs, right? Your airway, breathing, and circulation, and we're going to assess and manage each one of those. And so it could be said that you want to go back and recheck your interventions, but it might be too soon, right? Because this is really like a 30 to 45 second process where we're going to quickly go down, open the airway. We're going to assess their breathing. We're going to check for a pulse, skin temperature, color, and condition. And then after that, if there's nothing else that we need to treat to keep them alive, what comes after C? A doesn't come after C. You're getting there. You're 2 more letters. You got it. What comes after C? Yeah, exactly, D. And what is D? Remember that D is making our decision to transport or updating dispatch. Not all patients that we come into or that we arrive at need to go to the hospital. Not every patient that we take to the hospital needs to go with lights and sirens. And so what we're going to do is we're going to determine the priority of the patient, right? And then we'll either update dispatch, update the responding unit, or if we have an ambulance with us, we'll load the patient up and then determine, where we're going to go and things like that. At that point, once we've done our secondary assessment, we get into reassessment. That's when we're going to start rechecking our interventions. Does that make a little bit more sense? Cool. All right, so I have a case study for you if you're interested. So you're called to the scene of a 78-year-old woman complaining of shortness of breath. As you arrive on scene, her daughter lets you into the house and directs you over to her mother. The patient is lying supine on the couch and appears to be extremely pale and cyanotic. You hear snoring sounds when she breathes. The daughter states that her mother has a heart condition and she hasn't been feeling well for about 2 days. She thought her mother was napping on the couch, but when she went to wake her, her mother did not respond. So my first question to you is this a medical patient or a trauma patient?
Medical.
Okay. Does anyone disagree? All right, so we know what kind of, we know what bucket to put this patient in, right? We generally know what kind of assessment we're going to do. So upon arriving at the patient, what would be your first immediate action for this patient? Given the information I've just given you, what's the first thing you're going to do? So I see ABC, but remember ABC, that's 3 things, potentially 6 things. What is the very first action you're going to take? All right, I see a good answer here. All right, so I see a bunch of airways. I see a determined level of consciousness and a breathing. All right, for the folks that answered airway, what is the problem with her airway? What is she doing that makes you concerned about her airway? Snoring. Yes. What is snoring? Yep, exactly. So the tongue blocking the airway. So does anyone have the distinct pleasure of sleeping next to someone who snores? All right. And so when you nudge them really hard in the rib cage when they're snoring, what do? I think I see Melissa like miming things. Are you doing barrel rolls over there? Sit up gasping for air. Yes, that's an answer.
You get that.
They roll over, right? So if you're sleeping on your back and you're snoring up a storm, you sound like a chainsaw running out of gas, right? And you get elbowed in the ribs and you roll over. What position have you just put yourself in? Yeah, it's all coming back together. It's a recovery position. That's right. And so your tongue slides to the side of your mouth, your airway opens up again, and it's no longer obstructed. And so you're breathing normally, right? So snoring is a bad thing. Snoring is an obstructed airway. And when it gets really bad, you can have a condition called sleep apnea, where your airway actually collapses for a second until you get hypoxic enough to wake up, sputter for breath, and then fall back asleep. And so those people actually have really disrupted sleep. So snoring is bad. And so how do we fix snoring? We open the airway. So what maneuver are you going to use to open her airway? All right. So I like Andrew's answer the best, which is the head tilt chin lift. It's much easier than rolling a patient on her side because it takes a little bit of coordinated effort by a couple people. It's much easier to come over and just do the head tilt chin lift because, mind you, we may need to continue to assess this person from head to toe. We don't know yet. And so we don't want to put her into the recovery position before we know whether or not she needs medical attention, right? Because remember, the recovery position is for people who don't need continued medical care when your resources are overwhelming or your resources are taxed and you have to go and treat other patients. Otherwise, our patients lay on their backs and we give them medical care. So head tilt chin lift is a great answer. Would you perform a rapid secondary assessment on this patient? Or would you perform a head-to-toe secondary assessment on this patient, and why? Leo, I assume that's a yes because nothing immediately stands out, which is the right answer, but for the wrong reason. So you get half credit for that. There's a very simple reason why you would conduct a head-to-toe secondary assessment. Hopefully you open the airway and now she is getting enough air, so that wouldn't be a reason to conduct a head-to-toe. Now keep in mind that the daughter tells you that she hasn't been feeling well for 2 days and she thought that her mother was just napping. But she wasn't just napping, was she? She was unresponsive. Did not wake up when the daughter tried to wake her up. So lots of people have heart conditions that are up walking and talking and moving around and don't need a head-to-toe. The reason why we would do a head-to-toe exam on this person is because she has an altered level of consciousness. She is an unreliable historian because she is unresponsive to our check for responsiveness, right? So say, Mrs. Jones, can you hear me? Mrs. Jones, rub the sternum, no response. I think Mrs. Jones is unconscious. We're going to do then a head-to-toe exam. Now, how would you go about collecting a history from this patient? Exactly. Nailed it. Exactly. All right. And there's a few more questions here, but that's really aimed at an EMT audience, so we're not going to really dig into that. But does anyone have any questions about everything that we've covered tonight?